consultant, Central Melton Mowbray. So we'll give you a tour later on. We'll show you the tricks and secrets. We're surrounded by robots who are doing a great job. But in the interest of time, back to Mike to crack on with the meeting.
So we should probably introduce ourselves. I'm Professor Mike Grocott. I'm a Professor of Anaesthesia Critical Care from Southampton. Monty?
I'm Monty Mythen. I'm a Professor of Anaesthesia and Critical Care from University College London.
And we have a stellar panel this morning, and I'm going to ask them to briefly introduce themselves, then we'll go into the pre-recorded lecture, and then we'll come back for some panel discussion later. So if I go first of all to Ramani, a very old, as in we've known her for a long time, obviously very young friend of EBPOM, Ramani Moonesinghe. Do you want to give us a brief introduction?
Morning, everyone. Thanks, Mike. Morning, everyone. I'm Ramani. I'm a Professor of Perioperative Medicine at UCL as well, and I'm the National Clinical Director for Critical and Perioperative Care for NHS England and Improvement. And I'm a bit worried because both of my doctoral supervisors are on this call, so I'm worried that I'm due for some late homework marking.
We'll come on to that later. Kathy Rowan, also a young old friend.
Hi everybody, my name's Kathy Rowan. I'm founder and director of the Intensive Care National Audit and Research Centre in the UK, which hit its 25th birthday last year. Obviously I was a child prodigy when I set it up, and it's a real thrill to be here and join in the discussions.
And finally, for the moment, Sarah Hare, a newer but still very special friend of EBPOM's.
Hi everyone, greeting from Whitstable in Kent. I'm Sarah, I'm a consultant anaesthetist at Medway in Kent, and I'm the national lead for the National Emergency Laparotomy Audit.
Brilliant, thank you very much guys. So we've got a really interesting presentation, in fact two presentations, short presentations stitched together. So we're going to move to those now, and then we'll come back to the discussion element of this session a little bit later. So we could roll the presentation now, thank you.
Thanks to the organisers of EBPOM for this invitation to come and talk about the summary results of the SNAP2 EPICS project. And in particular, given the circumstances that we all find ourselves in at the moment, I think it's useful to reflect on what SNAP2 EPICS might offer us in the brave new world that we find ourselves in with coronavirus here, probably to stay at least for the short term. So what has SNAP2 EPICS, the study, told us that we didn't know before? This is what I'm going to go over in the course of the next 25 minutes or so. So the first thing is the scale of the problem that we had and probably still do have with the cancellation of inpatient surgery and the rates and reasons for cancellation of inpatient surgery with a specific lens on critical care capacity. The second thing is what clinicians think about the value of higher levels of post-operative care for high-risk surgical patients. So what they think the essential ingredients are of a higher intensity post-operative level of care. The third thing that we're going to talk about is some of the organically developed solutions that have come around to capacity issues for high-risk surgical patients in the NHS and indeed overseas. Fourth, we're going to think about how we might select patients to be admitted to high levels of care. So going over the methods that we might use for risk stratification of inpatient surgical patients. And then the final piece of the puzzle is what we think the potential benefits of post-operative high levels of care could be. So do we have any data to support the notion that critical care confers benefit on high-risk surgical patients? So to remind you, the SNAP2 EPICS study took place in 2017, and it looked at the epidemiology of critical care after surgery. And we took on the study because we reflected on the fact that at that time we had quite a significant problem with critical care capacity in the United Kingdom and indeed abroad, and that we felt that that was likely to pose a risk to high-risk surgical patients. And one of the things that we observed from national audits, studies such as the ISOS study or the USOS study, and also things like the National Emergency Laparotomy Audit and the PQIP study, is that although we have a threshold for admission of patients to critical care of a predicted 30-day mortality of 5% or greater, we know from these studies that that is not consistently applied, and there are quite a few surgical patients who would fall into the category of being, of needing to be admitted to critical care, who are not. And the reason for that, I guess, is probably obvious to those of you who work in critical care or in perioperative care. On a day-to-day basis, the consultant and the nurse in charge of the critical care unit will have to referee this battle that there could be between the surgical patient and the medical patient. The surgical patients on the whole are planned. Obviously, there are some emergency cases as well, but you at least usually have a few hours' notice of a surgical patient wanting to be admitted. But then also coming through the doors are the acute medical patients who might require urgent admission to critical care for a variety of reasons, and therefore on the whole would probably trump surgical patients if there was a shortage of beds. And of course this year we've got this new threat, the threat of coronavirus. In the United Kingdom we've just lived through hopefully the only surge, but certainly a very significant surge demand within the NHS as a result of coronavirus. And what has that taught us about UK critical care? Well, the first thing is that we have such a lot to be proud of, because the NHS in critical care, perhaps in particular, has demonstrated itself to be enormously resilient and adaptable. And one of the things that we've recognised is the fact that we can rapidly expand capacity in the case of a surge, in the case of this massively increased demand that we saw over March and April. But that comes at a cost. And of course, the reason that we were able to expand critical care so quickly was because we put a pause on much planned surgical activity. So going forward, we're going to have to manage in a COVID world, both COVID and non-COVID pathways for patients coming in for surgery, or indeed just coming in through the doors of the emergency department, and therefore COVID and non-COVID patients, aiming to reduce any risk of nosocomial infection with COVID or anything else, and accept the fact that that may sometimes mean that services are less efficient than they would otherwise have been. So that's the brave new world in which we find ourselves. So going back a couple of years now to when we did SNAP2 EPICS, the three things that we wanted to achieve through the study were these. The first was to analyse the epidemiology of critical care after surgery. The second was to engage clinicians in research using a citizen science approach. And the third, very importantly to me, was to support trainee leadership in the delivery of a major international research study. So what we did, the study had three parts. It had an organisational survey where we tried to understand the way in which critical care is provided to surgical patients. The second was we undertook a survey of clinicians, so anaesthetist surgeons and intensivists, to understand what their perceptions were around the management of the high-risk surgical patient and post-operative critical care facilities. And then the third thing that we did was a patient recruitment study, which took place for a week in each country that took part, and the three countries were the United Kingdom, Australia and New Zealand. So the first major output of this study was a paper which looked at the rates and reasons for cancellation of inpatient surgery in the NHS. And it was a 7-day cohort study in 245 NHS hospitals, which accounts for about 93% of acute NHS hospitals in England, Wales, Scotland and Northern Ireland. And we undertook two main analyses for this paper. The first was a hospital-level census looking at the number of cancellations and the reasons for those cancellations on a daily basis, and that included elective and emergency cases. And then the second was that we looked at individual patient analysis of those patients having planned surgery to look at the risk factors for previous cancellation if that patient had been previously cancelled. And we found the summary results that there was really quite a significant burden of cancellations. So the hospital level census yielded that 1 in 7 patients attending for inpatient surgery, whether that was elective or emergency, were cancelled on the day. And the patient level data told us that about 10% of patients attending for planned inpatient surgery and having their operation during the week of the study had been previously cancelled at least once. Looking at the reasons for previous cancellation, we identified that about a third of patients were cancelled for clinical reasons. And it's a regret of mine that we didn't record whether those clinical reasons were unpredictable or potentially predictable. So unpredictable might have been an acute infection at the time of surgery, which merited therefore cancelling the case. A potentially predictable reason would be, for example, not stopping drugs which should be stopped before surgery, such as anticoagulants. And in the future, we would certainly want to be able to unpick those sorts of things. And interestingly, within the NHS, although we collect data on last-minute cancellations, we only collect the data on the patients who are cancelled for non-clinical reasons. So understanding the clinical reasons for cancellation at the last minute is important when thinking about the whole pathway of perioperative care and whether anything can be done to reduce that last-minute risk. The non-clinical reasons for cancellation predominantly related to capacity, so lack of beds in the hospital, insufficient operating theatre capacity, so running out of time in theatres, and a handful of other reasons as well. If we look at this graph here, it shows us the patient level adjusted reasons for cancellation. So first of all, the good news, which is the patients that were the least likely to be cancelled are probably the ones that we really, really wouldn't want to be cancelled. So those having cancer surgery, those having expedited surgery, so that might be, for example, urgent vascular surgery, and of course those patients having obstetric surgery, and that relates predominantly to elective caesarean sections. The biggest risk factor on an individual patient level for last-minute cancellation was the requirement for a post-operative critical care bed. And so that in itself tells you the importance of understanding both capacity issues, but also whether or not critical care is actually potentially a benefit to a patient, because the last thing that we would want is for patients to be cancelled on the basis of needing critical care after surgery, when in fact that wouldn't necessarily be of benefit to them. If you look at hospital level impact or reasons why patients might be cancelled, the two biggest associations with last-minute cancellation were having your surgery in a hospital with an emergency department and having your surgery in a hospital with an enhanced care unit. Now, I'm going to come on to talk more about enhanced care units in a moment. My impression is that the reason that that was a predictor of last-minute cancellation is that those cancellations occurred in hospitals which had already identified a risk of not having enough critical care capacity, and therefore had created enhanced care wards in order to try and reduce the risk of last-minute cancellation, but they didn't necessarily completely cut out that risk. So the next set of questions that arises from these analyses are, what do we do in order to solve these problems? What's clear to me from looking at the data in detail is that we need system solutions. It's not just about necessarily providing more beds. Some of the things that we could consider, for example, would be reconfiguring services or ring fencing of beds. The obstetric case was a particularly interesting one to me. We all recognise that most obstetric units are ring fenced. They are self-contained units which have their own operating theatres, their own staff, and they do both a combination of planned care, such as elective caesarean sections, and really, really high-risk sudden emergency care, such as Category 1 emergency sections. So because we identified the fact that obstetric patients were so much less likely to be cancelled, I think that's an interesting case to look at to see whether or not we can learn something that can be applied more generally across the board. But we really do have to focus down on whether critical care in its current form provides benefit, because we recognise the fact that post-operative critical care requirement is a risk factor for cancellation. And a secondary important question is whether, if there is a benefit to critical care, whether that benefit could be conferred through provision of a different type of enhanced post-operative care without necessarily the need to go to an intensive care unit. So on that basis, we also then investigated what the provision of post-operative high acuity care was to patients in the UK, Australia and New Zealand. In this study, 309 public hospitals took part, of which 92% reported on-site critical care facilities. And in the three different countries, the number of critical care beds per 100 hospital beds was roughly similar, but you can see that the number of critical care beds per 100,000 population and the number of ventilated beds per 100,000 population differed quite substantially, with Australia having a much higher bed to population ratio than the UK or New Zealand. That, I guess, may in part relate to some of the distances in Australia being so much greater. If you look at the general ward staffing, so these are normal hospital wards, not critical care, not enhanced care, you see an interesting pattern emerge again, where the United Kingdom has a much less favourable nurse-patient ratio on its normal wards than Australia or New Zealand, both at day and at night. We were interested to find out more about enhanced care wards. We were aware, we'd heard stories that enhanced care wards existed, but what characterised them? We defined enhanced care for the purposes of this study as wards outside critical care and operating complexes, which offer some aspects of critical care, but not necessarily all of them, and have a higher nurse-patient ratio than normal wards. And what we found was a few interesting things. So the first thing was that where these enhanced care wards existed, they were predominantly led by surgeons rather than anaesthetists or intensivists or physicians. They were able to provide a variety of different interventions, but the key common characteristic was that they were able to monitor patients continuously, ECG monitoring, blood pressure monitoring, and so on and so forth. And the other key thing was that the patient-to-nurse ratios were much higher than normal wards, and actually equivalent to high-dependency units or level 2 units. The third study we did was a clinician survey to understand what clinicians felt about post-operative critical care versus ward care. And I'm delighted that this study, which has been led by a medical student, the analysis has been led by a medical student, Sophia Hashim, has just been accepted for publication in Anaesthesia Journal. And perhaps the most interesting aspects of the results of the study come through in the free text comments that we received. And the perceived benefits of post-operative critical care fell very clearly, to me, into two major categories. The opportunity to monitor patients more closely, as in the physical technological monitoring, and the second was the higher nurse-patient ratios. So here, a few quotes from consultant surgeons and anaesthetists with a lot of experience behind them, explaining what they felt the perceived benefits to be, and here further comments about the value of the higher nurse-patient ratios than are achievable on normal post-operative wards. Now, that's all very well and good, and wouldn't it be lovely if we could offer that level of support to every patient? But I guess two things are important to consider there. The first is it isn't going to be possible to provide that level of input to every patient after surgery. And the second is that probably it's not necessarily going to be of value to every patient. So patients having relatively minor surgery wouldn't necessarily benefit from that enhanced level of care. So how should we select patients for surgery? So that was one of the main questions that we were asking of the patient study, which was how should we predict post-operative risk? We have guidelines that say that every patient with a 30-day mortality predicted risk of 5% or greater should go to critical care after surgery. But what the guidelines don't tell us is exactly how we should predict that risk. So that's what we were trying to do with this study, which has now been accepted for publication in PLOS Medicine Journal. So over the week of the study conducted in each country, we included every patient that was did not opt out of the study, undergoing inpatient surgery, so requiring an overnight stay, and we loosely defined that as a procedure that required anaesthetic support. We wanted to compare risk prediction methods that were openly available to everyone. So clearly exercise testing is neither available in every hospital, but more importantly, it's not something that's available to emergency surgical patients. So we wanted to look at only things that could be applied to every patient, irrespective of where they were treated and under what circumstances they presented for surgery. So the way of doing that was to identify a few well-known, well-validated previously or new risk prediction tools, and the three that we focused on were the PPOSM, the surgical risk scale, and the surgical outcome risk tool, and evaluate and compare their accuracy. And the next thing that we wanted to do was compare how accurate these methods were with clinicians using their own clinical judgment about what the patient's 30-day mortality risk was. And so of every patient, we asked the perioperative team looking after them to predict what they felt their 30-day mortality risk would be. And the results of this study, so about 26,000 patients were recruited in total, and our analyses focused on 22,000 patients. We excluded the obstetric patients because there were thankfully no deaths in that group. and so we excluded them as a low-risk population that in this cohort would add no value to the analyses. We undertook several different analyses looking at both the validity of the objective models that have been previously described and also the clinicians' predictions themselves. So the first thing to look at is whether this was a generalisable population, and it's the reason that we were very keen to make this a non-consenting study was to avoid any potential risks that might be associated with a recruitment bias, which in particular might mean that high-risk patients were not recruited into the study. So of the patients that were recruited overall, we found that there was a good spread of patients across the different ASA grades, about a 60-40 split between women and men. 57 years of age was the median age, and a variety of procedure severity, but weighted more to the higher end of the spectrum, as one would expect for a study of inpatient surgery. We also conducted a number of analyses in a high-risk subgroup, and this was defined on the basis of previous studies, such as, for example, the VISION study, which articulated a high-risk subgroup on the basis of comorbidities and age. And if you look at the different surgical specialties involved, again, a good mix of different specialties across the board. As I say, we dropped the obstetric patients from the analysis, and a broad range of different comorbidities, which of course were more prevalent in the high-risk group. The cohort characteristics, if we look at the 30-day mortality, overall, this was 1.2%. And the important thing about this is that it was similar to the real-world mortality as evidenced by looking at administrative data, which was available to us from this paper published in 2017. So our overall cohort and our restricted subgroup of high-risk patients both match roughly to what we consider high-risk patients to be through epidemiological administrative data. We wanted to know how clinicians use risk prediction tools in general, and we found that the vast majority of cases, clinician judgment was the predominant way in which people assessed risk. There was a big group of people who used the ASA score, but very, very few patients had their predicted risk based on any of the objective scoring tools that are available, including the broader spectrum of tools and methods such as exercise testing and frailty assessment. So what we found in the past, this is from an editorial published some years ago, was an assertion that despite the fact that there are a huge number of risk prediction tools out there, that we use very few of them regularly in practice, and we certainly found that to be the case. When we looked at the three different models that we wanted to evaluate, we found that the calibration, so how well the observed expected ratios matched up, to be pretty poor, particularly at higher end of risk. But of all of them, the surgical outcome risk tool performed the best in terms of calibration and discrimination. If you look at how clinicians predicted outcomes, actually clinicians are pretty good at lining patients up in a row, so discrimination in terms of risk, but we're terribly glass half empty when it comes to whether or not that patient has a particular risk of death. So we vastly over-predict 30-day mortality. What we then did was look at a combined model which combined the surgical outcome risk tool assessment with the clinical judgment to see if it conferred any additional benefit in terms of prediction, and it does. Clinical judgment and the Swart were roughly equivalent, but the two combined together yielded a more accurate prognostication of surgical risk. So, the summary of that is that if you combine clinical judgment with an objective risk tool, you probably get the best possible prediction of outcome, and and that type of method will predict with a very high degree of accuracy, lining patients up in a row, so the discrimination between different patients in terms of their perioperative risk. So what do we know from all of this now? We know that we probably don't have enough critical care beds at the time that we did this study to meet demand for surgery 24 hours a day, 365 days a year across the United Kingdom, because we do see some last-minute cancellations that are related to capacity issues. We know that the main value of critical care after surgery is thought by clinicians to be continuous monitoring and higher than ward nurse-patient ratios, which is important because What people didn't say is, oh, it's because we can electively ventilate people or we can give them this particular type of fluid or drug therapy. It was more about the monitoring and the nursing ratios, which might therefore lend itself to thinking about whether enhanced care units, which have organically sprung up as a result of trying to meet increased demand for post-operative higher acuity care, could provide some of the answer outside normal critical care facilities, and therefore potentially reduce the risk of cancellation and offer a higher degree of care to a bigger number of patients. And then the final thing that we've summarised so far is that we can predict 30-day mortality risk reasonably accurately, but what we need to do now is really apply those methods in practice in order to risk stratify patients to the correct level of care after their operation. So the final big question from this study was whether or not critical care actually confers benefit for patients. And the answer to this is yes, it probably does. When you look at whether or not critical care is associated with a better outcome normally, the analyses are undertaken using regression analyses, and these are usually thwarted by this problem of confounding by indication. So it always looks as if critical care is bad for patients because patients are more likely to die if they're in the critical care category. But we know that that's most likely due to the fact that patients are higher risk if they go to critical care. We may not necessarily be able to measure that using tools that we normally use, but there's something that the clinician identifies as making the patient high risk that means they end up in ICU. There are some advanced regression analyses, causal inference analyses that can be conducted which address this problem of confounding by indication. And there's an abstract here at EBPOM, which has been undertaken by our medical student Tharusan, which will give you the results of a causal inference analysis of this data set, which is very exciting, I think, in terms of understanding what, if any, benefits there may be of critical care after surgery, but I'm not going to steal his thunder. So, to wrap up, what is critical care? Well, I guess it's all of these things. It's a place of higher level nursing care, 1 to 2 or 1 to 1, according to the guidelines for the provision of intensive care services published by the Faculty of Intensive Care Medicine. It's a place that we can do clever monitoring, it's a place that we can give clever drugs, and it's a place where we can use clever machines that go ping. But what is enhanced perioperative care? According to clinicians, the value of this might be in the higher acuity nursing and medical input than normal wards, but not necessarily as high acuity as HDU or ITU. It's a place that we can do continuous monitoring. I would say that clinicians generally think that that is one of the big values. Is it the place that we can give some clever drugs? Probably, yes, but perhaps not the full armoury of what we can offer in critical care. And is it the place that we can use clever machines such as mechanical ventilation and so on? Probably not for enhanced perioperative care. And therefore that does offer the opportunity for us to rethink whether or not we can expand the provision of this type of care outside the normal footprint of critical care and therefore offer value to a higher number of patients. Because what we know is that despite looking and looking and looking, there really does remain some equipoise over whether things like preemptive respiratory support, hemodynamic optimisation and so on, specific interventions offer any benefit to high-risk surgical patients. So what's in the secret sauce? I suspect it's really good high-quality nursing care and continuous observation and therefore early detection of post-operative deterioration. So our next big challenge arises not just from the landscape that existed when we conducted SNAP2 epics, but the new landscape that we're now living in as a result of coronavirus. So critical care probably does need to be expanded in the United Kingdom and potentially other countries where COVID is likely to be endemic in the short term. But we have a finite workforce, and so we can't suddenly just augment the number of critical care beds very quickly without rethinking how we deliver it. So could we deploy our workforce more effectively? Does every patient that currently goes to intensive care for high-risk surgical after high-risk surgery actually require a 1-to-1 or 1-to-2 nurse-patient ratio? Or could that care be delivered to the same level, the care that would benefit them, with a lower nurse-patient ratio and different focus in terms of consultant and medical support and allied health professional support? in the brave new world that we're living in, working in intensive care units, so level 3 intensive care units, where there could potentially be a lot of COVID, where there's the need to wear personal protective equipment all the time, these are going to become increasingly hard places to work, and therefore rotating staff between units like that and higher acuity than ward care, but perhaps lower acuity than level 2 or 3 care, may be beneficial to staff in terms of well-being and resilience, and to the system as well, because it may encourage us to train a broader number of staff in at least some of the basics of critical care nursing and medicine, and therefore again confer that benefit to more patients. So providing enhanced care for surgery might provide us with an important opportunity to both expand the number of beds that are available to look after patients who are at higher risk than a basic level 0 patient who needs to be in hospital for a few days of relatively low acuity treatment. But one of the big unanswered questions is what level of clinical staffing, both in terms of the expertise of the staff, the ratios and so on, what level of staffing do we need to provide to still offer benefit to patients having high-risk surgical procedures that don't necessarily go to an intensive care unit? So to wrap up, I'm just going to reflect back on the 3 aims of SNAP2 EPICS. So the first was to analyse the epidemiology of critical care after surgery, and I hope I've given you a reasonably comprehensive run-through of our results I hope, assure you that we've done that pretty comprehensively. We wanted to engage clinicians in research, and we wanted to support trainee leadership and delivery of major research. And I'm really delighted that we, I think, have achieved those ambitions as well. So far, there are 6 manuscripts either published or in the pipeline. So the protocol paper and 5 results manuscripts. 3 of them have been published by Danny Wong, who, at the time of recording this video, is about 3 days away from his PhD viva. So by the time you see it, I hope that he will be PhD positive. I'm sure he will be. And really brilliantly, 2 first author papers by medical students. So Sophia, who led the clinician survey analysis, and Tharusan, who's been leading the instrumental variable analysis, which is currently in preparation and is being discussed here at EBPOM as a finalist in the abstract competition. But again, the big success was the collaboration across the UK, Australia and New Zealand. More than 3,000 collaborators participating in the study, giving their time and their energy to the study and helping us undertake what I hope will be important analyses that will help us understand how we should be providing care to the highest risk of surgical patients. And so I'm really incredibly grateful to you for that collaboration, and to you also now for listening. Thank you very much.
Dear EBPOM community, dear colleagues, thank you for your appreciated invitation. My name is Tharusan, and I'm a final year medical student. And on behalf of the Surgical Outcomes Research Center at University College London, on behalf of the International SNAP2 Collaborative, I would love to invite you to take a look at our most recent results from our international study on morbidity and mortality risks after postoperative critical care. Next slide, please. So we all may agree that without an absolute indication for organ support, there is equipoise in the medical literature over which patients may critical care after surgery. On the one hand, we are all aware of the study by Brennan Cahan and colleagues from 2017 in London showing no survival benefit from critical care admission following surgery. On the other hand, publication by Steve Harris and colleagues from 2019 showing that there is a benefit after ICU admission for certain age groups and for patients with high levels of baseline physiological. And additionally, in our previous publications, we have shown that ICU admission is correlated with ICU bed availability. And with this evidence given, we have conducted a study to examine the causal effect of critical care versus surgical ward admission after surgery. on postoperative morbidity on day 7, secondly on 30-day mortality, and thirdly 60-day mortality. And the morbidity on day 7 was measured with the postoperative morbidity survey, which is also known as the POMS score. And first of all, similar to the previous literature, we performed a multivariable regression adjusted for observed confounders only. So we included 29 demographic and perioperative confounders, such as age, ASA, or procedural severity and urgency, or patient comorbidities. However, the problem of multivariable regression is that we only adjust for a limited number of observed confounders. So our association between the treatment group and the outcomes does not prove causation. And this is why, as a second step, we simulated a pseudo-RCT, so to say, by performing a causal analysis. So we applied a so-called instrumental variable method, which allowed us to adjust for those previously mentioned 29 observed confounders, as well as for unobserved confounders. Similar to the coin toss in an RCT, we included an instrument on ICU bed availability at the time of surgery. And in contrast to the multivariable regression, this instrumental variable method would allow causal inferences between the treatment group and the outcome. So we conducted a, could you switch to the next slide, please? We conducted a pre-specified prospective international multi-center cohort study in 248 hospitals across the United Kingdom, Australia, and New Zealand in the year 2017. So we included 21,935 adult surgical patients over 7 consecutive days, which underwent inpatient surgery without an absolute indication for postoperative ICU admission, such as cardiac surgery, aortic aneurysm repair. So in other words, we included a gray zone of surgical patients which could have been admitted to either level of care, to the ICU or to the surgical ward after surgery. And as previously mentioned, analysis was the traditional multivariable regression adjusted for observed confounders only. And our secondary analysis was the instrumental variable method, which allows us to adjust for observed and unobserved in order to make causal inferences. Next slide, please. Thank you. So on the left-hand side, you can see our results for the multivariable regression and the instrumental variable method summary outcomes. So 7-day morbidity, 30-day mortality, and 60-day mortality. And the results are displayed as risk ratios and 95% confidence interval. So similar to the traditional studies in the current literature using multivariable regression, ICU admission appears to be harmful across all outcomes. So to be more precise, ICU admitted patients had increased risk for postoperative morbidity, 30-day and 60-day. However, now, after adjusting for observed and unobserved confounding in the instrumental variable methods, ICU admission was still associated with higher risk for postoperative morbidity. But interestingly, ICU had 9% lower 30-day mortality risk and 10% lower 60-day mortality risk compared to the equivalent ward-admitted patients. So at this point, we were interested to further investigate this mortality benefit to admission. So on the right-hand side, you can see subgroup analyses on 30-day and 60-day mortality stratified by the surgical risk of patients. So the surgical risk was measured by the surgical outcome risk tool, the Swart score. And interestingly, the mortality benefits increased incrementally with critical care admission of higher risk surgical patients. So for example, critical care patients with a Swart score of 9% had a 35% lower 30-day mortality risk than ward-admitted patients. Next slide, please. In conclusion, we can say that ICU surgery is a double-edged sword. So although postoperative critical care admission means that patients are more likely to incur short-term morbidity, for example, due to invasive monitoring in the ICU, ICU-acquired immobilization, ICU admission confers longer-term mortality benefits at day 30 and at day 60. So presumably due to close patient monitoring with a 1-to-1 or 1-to-2 patient-to-nurse ratio, or due to advanced intensive care with comprehensive monitoring, medical devices, and drug therapy in the critical care unit. Finally, I would like to thank you very much for your attention. I would like to thank Professor Moonesinghe, Dr. Harris, and Dr. appreciated research supervision and mentoring. And I would also like to thank the 3,000 plus international SNAP2 collaborators. And I would love to take your questions and your further suggestions for this project.
Thank you for two really great presentations. So I think we've seen SNAP2, I think it's fair to say, in all its glory, not least as a group activity of Team Anaesthesia UK. So I'm not going to do the obvious thing and go to Ramani first and go to Kathy, but just before I do that, for those of you who are out there listening, please feel free to send questions in using Slido, which you should be able to see on your screen to the right of the screen where you're watching us. So, Kathy Rowan, you've seen this presented, I think, a couple of times now. How does SNAP2 fit into the kind of the narrative that we have of whether critical care works or not, or whether we're actually spending an awful lot of money on something that may be ineffective?
So my first reflections are what an amazing sort of study, what an amazing body of work, what an amazing collaboration, both globally and certainly I'm all for Team UK within the UK. And I'm really good to see the publications coming out, so those results being made available to everybody. I think we're always wanting to look at different ways to see whether we can identify whether or the benefit that critical care provides. I remember many moons ago, before the advent of high dependency care, I actually got a grant to do a randomized controlled trial to randomize lower risk critical care patients to high dependency care or critical care. But if you like, the tide overtook the ability to do that. So this is a wonderful body of work looking at sophisticated statistical analysis. I particularly like the representativeness. I probably would potentially challenge possibly whether the Australian and New Zealand data were as representative as the UK data, and then would want to kind of understand those comparisons. And it really sort of showed us the total burden that cancellation of surgery, think of the personal burden, the humanity of care, that notion of on-the-day cancellation or repeat cancellations for your surgery. I think interesting work around clinicians determining risk, and I think it's only human, if you like, to probably overestimate the risk in the hope that you provide the best care and get the best outcomes for your patients. And I thought that interesting information around using the risk tool and using the clinical judgment together, showing the value of both, if you like, the subjective, which is sort of measuring the things that you haven't got the data on, and putting the objective and the subjective together, giving us a better sort of notion of risk profile and risk prediction. And then I think the instrumental variable analysis, I worked with Steve Harris over a large number of years and was familiar with him developing those techniques. And it's just so wonderful to see them now moving out from his PhD, being used in other areas, if that makes sense. And, that is very compelling data in terms of causality. We always have the problem that even causal observational analyses don't necessarily give us the complete answer. So I think a huge contribution to, I think, the global literature around this. And I found myself sitting there thinking, it's now time for a trial, in my opinion. I do a lot of observational work. I do a lot of clinical trial work. And I guess I can see the possibility of risk stratifying patients and maybe conducting a randomized controlled trial, probably an equivalence trial. So you're not looking at whether enhanced care versus critical care, one is better than the other, but you're looking at, do they achieve the same outcomes within a sort of tolerance, if that makes sense? But understanding that the costs of providing critical care are very likely to outweigh the costs of providing enhanced care, and maybe looking for the best way to achieve best outcomes for our high-risk surgical patients, but also, spending our UK healthcare pound or our US healthcare dollar in the most appropriate manner. So I think an incredible study. I congratulate Ramani and the team and Team UK. Look at those hospitals and all the people who contributed. I just think it's a wonderful sort of representation of, we're very lucky in the UK to have a very, very strong UK research network at hospitals, and it's starting really to deliver for us, but also I hope delivering internationally and contributing importantly to the literature in this area. So congratulations, I've learnt a lot, and I think it's an important additional area in a gap that we knew existed. We knew the gap was there. They've identified and quantified the problem. They've identified perhaps a way of identifying the patients who might most need or might most likely fall into that gap. And they've given us some evidence that enhanced care, currently mostly provided, it seems to me, in critical care units, which may not be the best location for it, does confer a benefit. So I think, the future is very bright, but I think we maybe need to bite the bullet and do the randomized trial. Thank you.
Mike, Kathy, one of the things we're recognising here is the lack of beds. So if we want to randomise and commonly beds are not available, what do we do when the treatment's not available?
Yes, so you can build that into the design of trials. So when there's a trial that's evaluating a new bit of expensive kit, that expensive kit is, thankfully to industry very often, provided to the sites that participate in the trial. But you can't necessarily estimate the true number of recruited patients you're going to get at every site into a trial. So you can build into the inclusion and exclusion criteria of a trial the availability at the point of randomization of the two possible interventions that you're essentially comparing. So it wouldn't be impossible to have a trial where, at the point of randomization, so somebody is identified as a high-risk post-operative patient, that there is a sort of check that critical care is available, enhanced care is available, and therefore you go through to randomize. So it's no different to a close colleague and friend of mine doing the oscillating ventilator trial years ago, Oscar, where one of the the eligibility criteria was this, and the oscillating ventilator was available to be randomized to, if that makes sense. So I think it's possible. I think you'd need to carefully monitor what we call adherence in clinical trials. So you didn't get a sort of possibility not to randomize because there were beds available, but maybe it wasn't the right time of day or you were a bit busy or whatever. So you'd have to build in some monitoring and adherence checking, but I don't think it makes it insurmountable.
I'm going to come, Kathy, thank you. And I think, Ramani, it sounds like you got an A or A star from your erstwhile supervisor, so good result. I'm going to come back to the trial question a little bit later. And briefly, just before I move to Sarah, based on the current evidence, do we know that critical care is effective or do we not? So is that element of, do we need a trial there?
That's to me, is it, Mike?
That was just for a sort of yes/no answer from Kathy before I move to Sarah.
Oh, sorry, I thought it was to Ramani.
Sorry.
Do we know Do we know that critical care? So I think I'd push that back to you, Mike. Critical care is a real spectrum of care. Ramani indicated to us that there's lots of people, more people than not in critical care. There's more maybe, and she referred to it as cleverer drugs, and there are more and cleverer machines. Do we know all those constituents confer benefit? No, we don't. Absolutely not. And to some extent, we never have done the trial of critical care, but I think that there's enough well-conducted observational studies that would suggest there is clinical effect. The cost effectiveness of critical care, I think, has never been completely evaluated, but the societal value is huge, obviously. And look at the societal value of late with the global pandemic of COVID-19 and the role that critical care has played, and the heroes, the true heroes I've seen globally working in critical care to provide, incredible care to people over long periods of time to achieve survivors. So it's not a yes/no answer. I think we know bits work. I think we know some bits that we thought were exciting didn't work. But I think we deliver it with the intent that it is societally beneficial and something that populations want to resource.
Brilliant, thank you, Kathy, and very appropriate appreciation to all those who've been working really hard through the spring and summer in the face of the pandemic. Sarah, I'm going to move to you. So we overlapped a little bit working on NELA. You're now the clinical lead, and critical care has been very central to the data collected and some of the interventions, the quality improvement interventions from NELA. What's your feel from the NELA data about whether critical care works or not? And do you ever feel uncomfortable that there's a big push to have more critical care? Might we be doing the wrong thing?
Yeah, thanks, Mike. So I think we've really got to ask this question at the moment as well, given that so many of us are trying to juggle beds for our patients who are either green and screened and requiring them after elective procedures, and then we don't have enough beds to split it up for our patients who we haven't screened and understand whether or not they are at risk of having COVID or not. So we owe it to our patients to be able to keep them apart, which is a tricky thing. So we've got to ask these questions. What we've seen in NELA over the last 6 years of collecting data is that more and more patients are being admitted to critical care after their operation, which has been perceived as a very positive thing. And I think this year we found that 85% of patients who've got a predicted risk of death in 30 days of over 5% are going to critical care areas afterwards. Bearing in mind that around about 25,000 patients each year in the UK are having emergency laparoscopy surgery, that's a significant number of patients at each hospital. But actually, probably more interestingly, is that we've seen the number of patients overall after their emergency laparotomy going to critical care. So 63% of patients after their emergency laparotomy, all patients, will go to a critical care area. I think that's driven by projects like NELA. It's driven by the fact that we are hammering home the message to doctors and surgeons and anaesthetists that we have to consider how risky this operation is for our patients. And interestingly, actually, in NELA, 70% of patients are having a formal risk assessment, and the use of clinical judgment alone is less. And I don't know whether that's due to the messaging or due to the perception that these patients are super high risk. We must do a risk assessment of them. So more and more patients are heading to critical care. And I think whether or not we're doing the right thing there is the big question, because if you look at the patients who have an unplanned admission to critical care, that group have almost double the risk of death after their operation if they have an unplanned admission. So what is it about critical care that's changing things? 3/4 of that group of the patients who need an unplanned admission to critical care had been in critical care, gone to the ward, and then got readmitted to critical care. So there's so many things to unpick from that. Is that because we're discharging them too early? Is that because of pressures on the bed system? Is that because on the ward we're not able to recognise and rescue deterioration. And I think what we have to ask for these patients is, what are we actually doing for them? What are we doing? Are they having any organ support whilst they're there? Or is it simply that we need to get the basics right of warming them up, some good fluid balance, good pain management after their operation? And could that be done in a less invasive environment? And I wonder potentially if we were upskilling our nursing staff on the wards, if we were using enhanced care areas better, if we had more staff on the wards, then perhaps, and good nursing input, if they were able to do that, we wouldn't see this discrepancy between intensive care and ward care so much. So I think there's a need for a trial. I think we mustn't forget our emergency surgical patients. They sometimes are difficult to study by nature of what they're having done. But we certainly need to consider, what is it we're offering on critical care?
Very, very useful. I mean, I've always fondly hoped that the whole pushing towards risk adjustment and therefore because risk evaluation, and therefore because they're being evaluated, they're being sent to critical care, was one of the reasons that mortality has progressively come down for the emergency laparotomy population. But as you rightly said, there are a lot of reasons for that. So, Ramani, as I understand it, SNAP-2 happened because you couldn't do the trial that you wanted to do, and which was a trial of and Kathy's explained why it's a complex question, but is critical care effective or not? And that's because there was a belief that there simply wasn't equipoise and people wouldn't randomise. If we now believe it works a bit better, or we might have more confidence that it's more effective, does that make that challenge greater, or do you think there's more openness to answering these types of questions now?
Thank you, Mike. I think we might want to ask a slightly different question, and I think the landscape of perioperative care in the UK has moved sufficiently from when we first planned SNAP-2 in 2014-15 to now that we would be able to ask a slightly different question. So back then, the question might have been, is critical care effective? And the comparator would have been ward-based care. I don't think that we can justify that. I don't think that we can. I don't think that we would reach equipoise for that, and we didn't have equipoise for that before, because the surgeon or anaesthetist in charge of the care, particularly, for example, of the emergency laparotomy patient who was predicted at high risk, they're not going to randomise their patient to go to the ward if the critical care unit was available. So the question might instead be critical care versus enhanced care, as Kathy alluded to. I think one of the biggest challenges will be trying to decide the population that we want to ask this question of. So, for example, so the emergency laparotomy population, Sarah's described beautifully already. The population mortality for that group in the United Kingdom is between 9 and 10%. It has steadily dropped over the last 6 years since NEL has been in operation, which is terrific. But we also know that the population mortality for patients having elective cardiac surgery, for example, is of the order of 1 to 2%, depending on whether it's valves or grafts, primary or secondary surgery. So we know that there is a high risk group, as in emergency laparotomies, that while critical care admission after surgery has improved over the last 5-6 years since it's been under closer scrutiny, it's still not 100%. Whereas we know that I would guess that a cardiac surgeon would cancel a case if their elective cardiac patient couldn't follow the normal pathway of care for them, which would be transferred to something that looks like a critical care unit. We also know from cardiac surgery that enhanced care units have arisen within that population of patients. And therefore, the question is whether we can apply that logic to the more general surgical population. What Sarah was just saying about what is it, and Kathy indeed, about what is it in critical care that we offer that we believe to be of value. One of the things that was astonishing about the pandemic is that we seem to have done, the community, the global community, but particularly the UK community, has done a bunch of clinical trials very quickly, very effectively, very impressively, that have actually found interventions that work. And particularly steroids, obviously. Both perioperative care and critical care really struggle to find interventions that work normally. So, and in perioperative care, there is no magic bullet that I'm aware of. We continue to do trials of things like goal-directed fluid optimization that could be offered in a critical care or indeed an enhanced care unit if appropriately protocolized. We await eagerly the results of the PRISM trial of CPAP in the early post-operative setting led by Rupert Pearce and colleagues. But there is as yet no magic bullet. So I think the trial that we might do would be of highly protocolized enhanced care versus critical care. And we might want to choose a population such as for emergency laparotomy, for example, where one would be able to apply that principle that Kathy just described as, is the intervention available and therefore can the patient be randomized? Because I can see some logistical challenges with recruitment and consent if we were to do it in elective surgery, because obviously the screening and recruitment process would, I guess, be quite a lot earlier in the pathway, and then you wouldn't know if the bed was available on the day of surgery. I think there's lots, and I think the other advantage of the emergency laparotomy population, of course, is it has a very high morbidity and mortality, which is obviously terrible for patients, but it makes clinical trials somewhat easier in terms of the number of patients that would need to be recruited to see an effect. So that might be a way to go to try and further answer this question. But most of the key definitions, so what is it that they would get in enhanced care versus critical care? What would the staffing ratios be and so on? Later on this morning, some of the people that have been driving enhanced care guidelines over the summer will be able to speak to what those guidelines are likely to say. But a lot of the detail of the interventions is going to be necessary to achieve a result if we are to do something like this.
Brilliant. So we're overrunning a little bit, but we unfortunately had to start slightly late. So two quick answers. I've got one question from Slido and one question from me. So the question from me is which outcomes? Is it going to be effectiveness outcomes, or is it, as Kathy alluded to, going to be cost effectiveness outcomes? And the question from Slido is, what next for SNAP?
One of the other oh, sorry, Rams. I was going to say one of the other outcome measures. One of the outcome measures that's not been mentioned there is patient-reported outcome measures and patient experience. And just in the little pilot work that we're doing at a couple of hospitals, talking to emergency laparotomy patients after their surgery, one of the things they find really frightening is when they step down from critical care to a ward in the UK, and the difference in the input from nurses, communication, regular ward rounds. So I think that should be part of our outcome measures, is patient-reported ones.
Absolutely. Rams.
Yeah, I fully support that. I think in terms of, I think Kathy's idea that this would be an equivalence study, a non-inferiority study, as opposed to a definitely showing benefit for one intervention over the other, I think is right. And I would probably go for something, is really putting us on the spot here, but I would go for something that would be potentially a combined outcome of something like days alive and out of hospital, for example, at a defined endpoint like 30 or 60 days, because that gives you that measure of both mortality, which in most surgical procedures is quite low, but also morbidity. In terms of what next for SNAP, SNAP 3 is in the planning stages. An advert's gone out for the trainee lead for that. It's going to be led by Ian Moppet, who you will all know is a professor of anaesthesia in Nottingham, and Jude Partridge, who's a geriatrician at St Thomas's, and they're going to be evaluating frailty and delirium using similar methodology to the previous SNAPs of big cohort, mass participation, and I hope international participation as well. But more details to come about that in the near future. But trainees, please look out for the adverts for the trainee leadership.
Brilliant. Very exciting that momentum is being maintained. So I apologise for having to truncate this discussion. It's been really fascinating and hopefully useful. Apologies to our audience for overrunning a little bit. We do try to respect your time, but hopefully you'll come back and join us at 10:30 for session 2. What does post-operative critical care look like? We've got a presentation from Michael Swart, who I'm sure you're all familiar with, and then Denny, Levett, Stuart, McCorkell and Chris Snowden contributing to the discussion. So thank you very much for listening. We look forward to seeing you in just under half an hour, and thank you so much to our 3 panel members and the presenters.
Welcome back to this Post-Operative Critical Care Summit, part of our EBPOM USA meeting, coming to you live from Chicago, although at the moment we're here in the UK-based studio. That's an EBPOM pop-up studio, here at the Stream Room headquarters in Melton Mowbray, the home of the pork pie. So if you missed the first session, I know a few people were struggling to get in via various different routes, so apologies to that. You will be able to watch the replay of everything. So just to reintroduce ourselves, I'm Monty Mythen. I'm a professor of anaesthesia and critical care at University College London, and I'm one of the co-directors of evidence-based perioperative medicine, and I'm joined by Mike Grocott.
Morning. I'm also a professor of anaesthesia and critical care, but at the University of Southampton on the south coast, and also a co-director of evidence-based perioperative medicine.
So this summit was Mike's idea to take the opportunity in advance of our EBPOM USA meeting to consider post-operative critical care in the wake of what we hope was COVID-19, but perhaps the first surge of COVID-19. And as part of that, we're now going to do a session which is about what could or does post-operative critical care look like. So we've got two guests joining us. We've got Mike Swart and Denny Levett first. Mike, Denny, hi, how are you? Mike first.
Hi, Monty and Mike.
Morning, Michael.
Michael, a quick thumbnail sketch. Who are you, and what are you doing here?
Who knows? I'm a consultant in anaesthesia, critical care and perioperative medicine, Torbay, south coast of England, and have been for the last 22 years. And I've had an interest in post-operative surgical care. I'm also a getting it right first time anaesthesia and perioperative medicine clinical lead, and that's about looking at variation in perioperative medicine across England.
And Denny Levett, welcome. I think that's a lovely new bookshelf behind you there.
Thank you, Monty. So yeah, I am a professor of perioperative medicine and critical care and anaesthesia down in Southampton on the south coast. My clinical interests, I'm a lead for our elective critical care unit. We have a level 2 unit, and I'm also involved in trying to set up an enhanced care unit for some of our surgical patients as an in-between. From a research perspective, I'm interested in the care of high-risk patients and trying to risk stratify patients preoperatively and thus, optimize their perioperative care, including trying to decide which is the best perioperative environment for them.
Now, we'll be
Thanks very much.
Thank you very much, Denny. So there'll be more people joining our panel towards the back end, but first we're going to have a lecture from Mike Swart about what does post-operative critical care look like. Now, you watching online can ask questions, so if you go to slido.com, the code is EBPOM, E-B-P-O-M, little dash A, so EBPOM A. Please do submit questions online and we'll get to ask our presenters and our panel later on. So Mike, a lecture from you. Please take us away.
Hello, my name's Mike Swart. I'm talking to you today from Torbay Hospital in South Devon, United Kingdom. I'd like to start by thanking Ralph, who's filming this for you. So today I'd like to talk about access to critical care for high-risk surgical patients. Before going any further, I probably should declare a potential conflict of interest. My hospital has a pharmaceutical unit that manufactures metaraminol and sells it widely around the UK and the rest of the world. I'm not sure if this is declaring a conflict of interest or blatant advertising. I'd like to reassure you that all profits go back into the UK NHS. So my talk today is in 3 parts. First of all, a bit on variation in access to critical care and behaviours in decisions on use of critical care. Then I'm going to move on to describe some of the things we've done in Torbay over the last 20 years to improve access to critical care. And finally, I'm going to summarise on where I think we've got to today. So variation and behaviour. This is a slide showing the variation in number of intensive care beds per 100,000 population around the world. Australia and New Zealand weren't in the table, so I've added them in, with Australia at 9 beds and New Zealand around 6. Now, what you can see is there is big variation. Now, part of this may be due to the description of what an intensive care bed is, but I think it is a clear indicator that equity of access is not the same around the world. And the UK sits at about 6.3 beds per 100,000, with Germany at the top. There's also variation within countries. I've got a role in something called Getting It Right First Time with a colleague, Chris Snowden, up in Newcastle. And we're doing the perioperative medicine theme for this. And it's involved us going around England, visiting over 70 hospitals. And what's absolutely clear is there's wide variation in what access patients have to post-operative critical care after surgery. Examples where access is good are the Royal Surrey Hospital in Guildford and a UCH in London. Now, I'm not criticising them by having good access. I think they have the access that the rest of us are envious of. But why they have it and others don't is a complicated and interesting topic. There's also variation in decisions on who would go to a post-operative critical care unit. If we used mortality, you would expect some consistency across surgical procedures, but that doesn't exist, and it hasn't changed that much over the last 20 or 30 years. For example, elective coronary artery bypass grafting has a 30-day mortality that is under 2%, whereas an emergency laparotomy has a 30-day mortality of over 10%. Now, nobody would start cardiac surgery without a post-op critical care bed, but many of us have to start emergency laparotomies without that luxury. I'll give you another example locally in Torbay. We've developed a post-operative form of HDU for elective hip replacements if their predicted 30-day mortality is between 1% and 3%. Now, that's for the electives. For hip fracture patients who have the same operation but have a much higher mortality, we don't put them in this critical care or HDU facility. And in fact, they leave the same operating theatre, go down one corridor and either turn left to the HDU or right to the normal ward. So that's elective surgery goes left and emergency surgery goes right. Now, if I spoke to the public about this, I think they would find this rather odd. Another example of variation around the country is in vascular surgery. For example, some places, all endovascular aneurysm repairs, or EVARs, and carotid endarterectomies will go to HDU, whereas in other trusts or hospitals, they go to recovery for an extended period of time and then back to the normal ward, unless there is a complication in the first few hours following surgery. So, what have we done over the years about this? First of all, I'd like to ask, and usually at this point I ask people in the audience to put up their hands, but clearly that's not an option. But I'll still ask the question, how many of you have read a randomized controlled trial on HDU care after surgery? My experience in asking this question in the past is not many hands go up. There is one. It's from Torbay. A number of years ago, we used an anaerobic threshold of above or below 11 as a cutoff to select high-risk patients after colorectal surgery. And we randomized them into two groups, those that went to HDU and those that went to the normal ward. And our outcome measures were adverse cardiac events, defined as a myocardial infarction, acute left ventricular failure, or a cardiac arrest. And in this group, the top line is those who are deemed fit and not randomized, and there were no cardiac events. Then in the next two lines, there were 51 patients that went to HDU and 32 to the ward. This was, the randomization was set to do this. And our outcome was 7 cardiac events if you went to the ward and none if you went to HDU. Now, what value is this paper? Probably very little, in that it's achieved very little change in post-operative care. What it did do, though, was teach John Carlisle and myself a little, throughout the thinking we did over this, a little bit about risk prediction. And here's a photo of a younger version of John Carlisle on a cardiopulmonary exercise test. So over the time we were doing this study, 3 things happened. We developed, or rather John developed, a risk prediction model for post-operative 30-day mortality. At the same time, we also developed a perioperative medicine clinic that used or developed shared decision-making for high-risk surgery. We also realized that if you're going to study HDU, you have to first define what it is. So this is the definition that you need to define the reason for going to a high dependency unit. So this is what we came up with. We came up with a plan in Torbay that if your predicted 30-day mortality for elective surgery was greater than 4%, you would go to an HDU bed, and if there wasn't a bed, your surgery would be cancelled. We then had a group with a predicted 30-day mortality between 1% and 3%, who, if there was no bed, you discussed between surgeon, anaesthetist, critical care, whether to proceed or not, and you may or may not proceed, depending on that consultation. And then those with a predicted 30-day mortality of less than 1% were allowed to proceed without an HDU bed. Now, we thought this was a reasonable way to do things because it gave clear definitions to the greater than 4% and less than 1%, but allowed for some variation depending on individual patients or surgical procedures to influence the decision. It did work, but it also had some side effects. The side effects were unhappy surgeons because of cancellations, unhappy managers because of fines from the trust, because of long waits for certain procedures. And it also did cause a little bit of disagreement in that some people didn't believe we were able to do predictions of 30-day mortality and didn't believe there was any evidence for the use of HDU. I think what I learnt from that was when somebody tells you there's no evidence, it means they don't know what the evidence is. So what happened next? We had 2 groups. We'd have people who interpreted the discuss before proceeding as they don't need a bed, and other groups that went, well, if there's a bed, we'll use it. And in the end, the solution that was proposed because of the disruption this caused to surgery was to stop the clinic. The feeling was we made these risk predictions in the perioperative medicine clinic. If we didn't see the patients in the clinic, then we couldn't say they needed HDU care. This unfortunately wasn't true. All that it would mean is we wouldn't have the benefit of seeing the patient, doing a cardiopulmonary exercise test. All we would have is the notes to determine their predicted 30-day mortality, which would have actually increased the demand for HDU care. So there was a meeting with our medical director over this, and a decision was made. Now, fortunately, we had some other evidence about our clinic and decision-making from the clinic and post-operative care. This slide shows a study of 314 patients who had colorectal adenocarcinomas. And these 2 survival lines are patients referred to the clinic and patients not referred to the clinic. Now, at that time, the referral to the clinic was determined by the surgeon. And if they didn't think the patient was unfit, they wouldn't refer. Now, what we've demonstrated here is in these 2 groups, you lived longer if you went to see us in a clinic. Now, the probable reason for that is you got HDU care. The two groups were almost identical in terms of cancer and cancer staging. The group that came to the clinic were older, had a higher ASA and had higher creatinines. Now, the advantage of this study that, again, people are probably not aware of, is it helped us in our discussion with the medical director. We were able to ask the medical director if people who went to his gastroenterology clinic lived longer than those that didn't. He wasn't able to answer the question. Final study I'm going to mention, from Torbay again, is a study that looks at decision making. Now, I'm particularly proud of this because I don't think we study decision making. We may study one test over another test, or one drug over another drug, or one operation over another operation, but we don't study the overall decision making and outcome. So what we did here was we had this cohort of patients who were either in the greater than 4%, the 1 to 3%, or the less than 1% predicted 30-day mortality. The greater than 4 predominantly went to the intensive care unit for HDU care, and the less than 1% went to the ward. And then in the 1 to 3% group, we had some that had HDU care and some that didn't. And I'd like to show you the results of that study. Now, this at first looks a bit complicated, but if you just start looking at this as a flow diagram going from left to right, on the left you have patients seen in a clinic who are given a predicted 30-day mortality based on age, operation, comorbidities, and an exercise test. They're then put into 3 lines, greater than 4% who go to HDU, 1 to 3% who could go HDU or ward, and less than 1% who predominantly go to the ward. Now, if you look at the top at the red, of those that went to HDU who were the highest risk, 4%, the figure of a surgeon means they went back to theatre post-operatively. The figure of a bed is they returned for an unplanned ITU admission at 9%. And then the final figure is the cost per patient that we estimated. Looking at the middle yellow, HDU or ward, of those that went to the HDU, nobody went back to theatre and nobody had an unplanned visit to the intensive care unit. Of the yellow line that went to the ward, 10% went back to theatre for things like an anastomotic leak or a collection, and 16% had an unplanned admission to ITU. Now, what I think we demonstrate here is an assessment, a decision-making, and a process, not just one option, result in a different outcome. And finally, it's not more expensive. Your excess intensive care costs outweigh your high volume but lower cost HDU costs. So what have we achieved over this time? This may look a little bit depressing. We have 2 what we call level 1.5 beds for enhanced care for orthopaedics. The reason we had them for orthopaedics is the cancellations that were costing the trust were in orthopaedics and not colorectal surgery. But I still think we have achieved something. It's been running for, in a few weeks' time, because we started in June, it will be 4 years. And what did we do? We used arterial lines, arterial lactate measurements, metaraminal for hypotension, magnesium and amiodarone to treat AF post-operatively. And we did this on an enhanced ward. So it was 2 beds on the normal orthopedic ward, backed up from the critical care unit. And it's worked. We haven't had complications, we haven't had cardiac arrests. Our only unplanned admissions to ITU, or almost all our unplanned ITU admissions, are because it closes on a Saturday. We've also learnt it's not just about the arterial line and the metaraminal. It's about the whole care. And starting at the bottom, it's about providing an environment that has shelter, warmth, food, private access to toilets. Now, these things are not normally available in an intensive care unit. We also need access to Wi-Fi these days to communicate with friends and family. It needs to be a quiet, calm environment. And again, I don't think an intensive care unit covers that. It also needs active involvement from physios, OTs to do the enhanced recovery bit. We were finding in the intensive care unit, if you went there, they didn't get you out of bed because the priority was the sicker patients. Also, visitors. Visitors find the environment of an intensive care unit more intimidating than that of the normal ward. Finally, going to come back to behaviour. One of the problems in developing this has been in behavioural attitudes that within intensive care, the emphasis is on sick patients. And I'm talking particularly about UK intensive care. And once somebody's well enough to not need a ventilator, they are discharged. Once somebody no longer needs vasopressors, they are discharged. Also, you don't admit them until they need them. Whereas in our enhanced care area, we were finding that 40 to 50% had an intervention that they couldn't receive on the ward, but 50% were not needing it. But if you follow the ITU admission criteria, you would not get considered for admission until you develop the problem. And then the problem can't be treated until you're transferred to the intensive care unit. Now, these behaviours, I think, are intrinsic within how you are trained in intensive care medicine and also part of the behaviour of people who work in intensive care units. And I have to state, my background is in intensive care. I think this is one of the most important papers I've read in the last few years. And what it highlights is the gender disparity within consultants in UK intensive care units. And I think with that comes behaviour change, differences in behaviour. The focus on the high risk, the complicated, the complex, the clever machines, the clever drugs, that's the interesting bit. Whereas the HDU bit, a lot of people from intensive care are not really interested in that. Finally, I'd like to end on, this is probably the biggest achievement. This was published in May 2020 from the Faculty of Intensive Care Medicine, where finally we've written down some guidance on doing something that is in between the intensive care unit and the ward. And that will be part of another talk by Anna Batchelor in EBPOM 2020. Thank you very much for listening and watching.
So what post-operative critical care could look like in the future. So it looks like enhanced care as a badge is here to stay. So for those of you who might have joined us a little bit later, Monty, Mythen here, I'm chairing this session along with my co-chair, Mike Grocott, who'll be looking after the questions coming in online, which is on slido.com. The code is EBPOM, EBPOM, _A. We've already been introduced to our first two guests and our presenter, in particular Mike Swart, joined by Denny Levett. Now I'm going to introduce the rest of our panel. I'm going to go around and ask them to give a brief introduction, then I'll come back to them and ask them to comment on Mike's presentation. So Stuart, if we could start with you.
Hi, good morning, everybody. My name is Stuart McCorkell. I'm a consultant anaesthetist at Guy's and St Thomas's Hospital in London. And I've been running a post-operative level 1 to 3 integrated facility, if you like, the overnight intensive recovery for the last 15 years or so.
Chris Snowden.
Oh, hi. Hi, everybody. I'm a consultant anaesthetist, have been for 23 years in Newcastle upon Tyne in the north of England. My interests really have been high-risk surgery, including liver transplantation, and the management of those patients post-operatively. And I'm very interested also in preoperative assessment of those high-risk patients. I share national clinical get it right first time lead with Mike Schwartz.
Thank you. Welcome. Ganesh.
Morning. So I'm Ganesh Thrulingham. I'm the president of the Intensive Care Society. I think I'm here mainly with that hat on. Clinically, I work as consultant intensivist and anaesthetist in Northwest London. And actually, we have what's now our post-anesthesia care unit, but originally an OIR modelled on the one at St Thomas's, although smaller. So that's clinical experience.
Brilliant. Thank you very much. And thank you very much for all your national work. Thanks for everyone for their national work. So, Denny, we're going to come to you first. So, Denny, as you were first up, if you could comment on Mike's presentation and then share with us your personal views on where we're going. We can't hear you at the moment, Denny. I'm not sure if you're muted at your end or muted at our end. Okay, we're going to come back to you, Denny, if that's okay. So we'll come back to you shortly. So, Stuart, you were telling us about your endeavours. What did you make of Mike's presentation?
So I think that's a really good view of where we need to be heading towards in terms of the gap between critical care and ward care. And I think one thing that strikes me is that there's going to be a plurality of solutions which are going to have to fit the local institutions. And that's going to depend on the case mix. Different subspecialties have different needs and different timescales their patients require this further level of care for. And it's going to depend on the local resources as well, and the size of the institution as well, because there are economies of scale combining multi-specialty patients perhaps in ward or critical care environments. And there are other smaller, more bespoke solutions, and Mike's nicely described their initial two-bed bay in orthopaedics. And I can see a panoply of different solutions across the UK, really, to meet this need. I think one of the challenges is how we can have an overarching sort of support for that, particularly in terms of the financial and resourcing aspects.
So, Stuart, it's about 15 years since myself, Mike, and some others co-authored a document about the modernisation of care of patients undergoing major surgery. And in that document, one of the examples we gave, because you said there are different solutions that are available here, was the overnight intensive recovery unit at St Thomas's. And we kind of thought that within a few years of publishing that beautiful glossy document and it getting into government speak, that this would all be ancient history by now. Why do you think that we haven't? Because it seemed like the real estate is there, the monitoring is there. Why not just let people hang out for a bit longer?
You mean hang out in a critical care area?
Like at the time you had an overnight intensive recovery.
Yeah, I mean, so why do they only stay a night?
Or why in most places do they only stay a few hours is what I was getting at, Stuart. So in your place they can, as we understood at the time, they can stay a night, and in our place they cannot stay at night. So the real estate is empty at night, if you see what I mean.
So I think some of that's volume, isn't it? That you have to clear the decks for the next day, and it's about the staffing of that out of hours. And out of hours presents a real challenge. And actually, one of the issues is we are talking about arrangements that may come under a multiplicity of different directorates. So if we look at the whole breadth of enhanced care, I don't want to talk really much about medical enhanced care here, but it's going to be different directorates controlling these services in different hospitals. And that I think that it's simply those structural problems as to who does this and when do they do it and how long do they do it for that is a real barrier. And we've kind of been stuck in our model in that we're in one location. And actually, Mike really nicely highlighted some of the advantages of being in a ward environment for these patients with access to daylight, windows, normality, meal trolleys, communication with family, although that's a challenge at the moment. And that's something we can't offer in our environment. And one of the restraining factors in bridging that gap is just the provision of that framework, that light touch framework that needs to be there medically to support these patients. And who does that? Is it the surgical directorate? Is it anaesthesia? Is it critical care? But I think local solutions are going to need to be the answer here.
Thanks, Stuart. We'll come back to you. I think, Denny, we've got your audio back.
Yes, hi, thanks. Can you hear me now?
We can.
Sorry, I missed some of that, so I'm sorry if I'm repeating anything that Stuart said. I just thought you should be congratulated, Mike, on a persistent, a long body of work over a long time and making massive progress in a difficult environment to end up where you are. I agree with many of the challenges we've all talked about, that a general intensive care is perhaps not a great environment for most elective patients who really are there for prophylaxis. There's a small group that require ventilation or actually some organ support, but most of these patients require prophylaxis and preventing something happening and early intervention. And I agree with what Stu was saying, is that some of the challenges are how we staff this, how we best organise this outside critical care, because certainly in my institution there's now an enthusiasm for every single specialty to have their own level 1+ on lots of different wards, and you can see that could lead to problems with lots of pockets of in between patients with higher acuity needs. So I think we need to think about a framework of what would be the limits of what the sort of care we can provide in these areas. A staffing model that I think needs to be integrated. So I think certainly early on there needs to be some input from critical care, but I think if we said that everyone needed to be critical care trained, for example, that would be a barrier, and it's a real opportunity to work with junior surgeons, other specialties. But I agree the out of hours element of that needs to be addressed, and I think a shared care is going to be the way forward in these environments. But it's how we structure that, and probably how we group these patients together in one level 1 area, level 1+ area in the first instance, rather than having multiple areas where we could have problems. Because the staffing will be a challenge not only for the doctors but also for the nurses, because they haven't looked after these patients sometimes for a prolonged time, so there'll be a transition when they get used to some patients that have perhaps been in a high dependency area before.
Denny, thank you. We'll come back to you. Chris?
Yeah, I mean, when I started anaesthetics a long time ago, or just mid anaesthetics, as I was starting to think about what specialities I was going to do, I always looked at the seniors to see what they were actually doing, and the availability of monitoring arterial lines, central lines, etc., was what we were brought up on. But the seniors were actually reducing the amount of invasive monitoring, etc., that they were producing, and I thought they were mad initially. But as we get older, you do realise that actually most of our patients require a much more minimalistic attitude in terms of how we monitor and care for our patients. And I'm looking forward to the days when we do accept that our patients need critical care in some shape or form. But the way we should be looking at that is that we should be trying to differentiate which patients actually need care to prevent deterioration in those ones that are likely to go that way. But there's also a huge group of population of patients that actually we should be just looking towards enhanced recovery in patients who already have the trajectory that's upwards. So these are the patients that I think enhanced care should be really important. And there will be cases to a more higher intensive care sort of positioning, but that doesn't mean that we can't still retain that sort of patient-centred care, holistic care that we require. And enhanced recovery's got to be in there, and there has to be more use of some of the technology. And most of our patients now, even at high risk, who go into intensive care, are awake. They're very rarely intubated. And they need contact with not only the nurses that are looking after them, but also their relatives, and keeping them sane. So I'm looking towards downgrading a lot of our intensive therapy that we've been using in the past.
So Chris, a number of years ago, you introduced in a presentation the concept of PERU, P-E-R-U. I think recognising the fact that if our patients go to main intensive care, they're at risk of being treated like an intensive care unit patient and kept in bed. Whereas if they go to the ward on an enhanced recovery pathway, it's drink, eat, mobilise. And I think the idea of Peru was something in the middle. Did that play out?
Again, it was around infrastructure and the problems of gaining where you can actually do this. And I think Peru actually became a recovery area, a prolonged recovery area, which I think Mike's alluded to in his presentation is actually a relative, or he has said in the past, a torture area, i.e. a patient is in a recovery area with a lot of patients who are maybe in pain, and it's not the environment to transfer an enhanced recovery process to. How I see some of this enhanced care occurring is that this is a ward-based care almost, with an enhanced program of monitoring, but also with a huge multidisciplinary team getting in very early, including physios, including pharmacists, and making sure that that patient is mobilising, whether they're in an upgraded area or within the ward. So to me, an enhanced recovery programme is absolutely key.
Thank you. Ganesh, your opening comments.
Thank you. Thanks for a very nice talk, Mike S. And a very sort of sustained and dedicated body of work over many years, as others have said. And I think one of the things that struck me about the talk is you've been rightly very open and transparent about the challenges in the UK. And I think somebody listening, obviously this is a substantial international audience, and if they're listening to the kind of story of turning left versus turning right, there may be a few sort of jaws hitting the floor, because that may just be very non-standard elsewhere, but it's absolutely true, and you're very right to bring it out. I think so I'll make a sort of a comment and express an anxiety and ask a question for you to talk about later, maybe. So the comment is, I think the things you very well described as the benefits of an enhanced care environment and pathway, in terms of being very patient-centered, in terms of all the sound and light, and assuming this will be an awake patient or will be very shortly, and a focus on their kind of human needs and recovery. I think I would say those should be the aspirations of intensive care as well. I think at the moment there is a model, and I think this is partly a function of the UK setting where ICU is a weapon of last resort. And therefore there is a tendency for it to be the sort of steel cave lined with cables and wires, and a kind of laboratory of extreme physiology. But actually globally there are units where there's only 30% of people ventilated, and actually a lot of this they would regard as standard of ITU as it evolves. And I think the direction of travel here at ITU conferences is around humanising the unit, both in terms of environment and also importantly about making the rehabilitation and mobilisation of patients a kind of priority from day one, including things like early mobilisation of even of intubated patients. So that's a lot of the comment. I guess the worry is, are we building a potentially another barrier? In that we've talked about the distinction between ward level care and the sort of hurdle for HTU in terms of access and numbers. If we solve it with another area, are we potentially then making a different barrier between that and critical care? And I guess my worry is that it's actually to the detriment of critical care. Maybe we should be taking all the things you've said and redesigning our ICUs to deliver that in a flexible way, so that both an awake patient or a definitely awake and conscious family will get the same sort of standard of care, if you like. So we're working on the premise of the patient recovering and working backwards from there to add in any further technology and interventions. So I suppose my question, that's my anxiety, is we may be missing an opportunity to improve critical care as a whole. Obviously that's slightly for the ITU community to address. My question to you is, if, God forbid, there was a major seismic event tomorrow and Torbay Hospital fell over, and you had the opportunity to rebuild it from scratch with billions of pounds and all the staff you want, do you think, would you choose to have a separate enhanced care area, or if you could build the world's best ICU, would you say the global standard of care would be actually covering the full spectrum in an integrated way?
Mike, back to you. Do you want
So
take
to
that,
me?
Mike? Yes, because that was,
Yeah.
I think that was a direct question to you from Ganesh. Thank you very much.
Okay.
Ganesh. Great comments.
Yeah.
I'll deal first with should this be intensive care and does intensive care need changing? The answer is it could be. The reason I've gone though for it's outside of intensive care because I failed to be able to change intensive care to what you've just said. And I failed to change it because of the behaviour and attitudes of doctors and nurses who are trained in intensive care in the UK. And that's my background. So in a way, I sort of gave up on intensive care because I thought they were the problem. But if you could do what you've just said, I would completely support it. Because I'm not about it should be in one place or another. I think going back to some of the other points people have made, I think there are principles of how you do this, and then where it takes place and who does it, determined locally. Then this second bit, the question, I have thought an awful lot about how I would rebuild a hospital if I had all the money I needed and started from scratch. And I think I would develop two sort of types of hospital. One would be the acute hospital where every patient would be an enhanced care area. And then when you no longer needed that, you would either go home or you'd go to rehab. So I would, if I was rebuilding, I'd have a lot of enhanced care capacity, but I'd also focus very much on rehab.
Right,
Can he give you the money?
I think it was promised, wasn't it?
Sounds good to me.
I heard the promise from the Chancellor, anything you want, it's not a problem. Mike Grocott, do you have a comment, I think?
Well, I'm just sort of reflecting on the interchange between Ganesh and Michael Swart. It's always fascinated me. So I am an intensivist, and like intensivists, I get very excited about lung injury and sepsis and all the big machines and the flashing lights. But I'm also an anaesthetist who is very passionate about perioperative care. And in some of my intensive care colleagues, that bit of the brain seems to be missing, or that passion seems to be missing. And there's a sort of almost a binary divide between those who see the opportunities of perioperative intensive care as a really important element of the path forward for critical care, and those who see it as just something really different and a bit of a distraction, and frankly, they're not sick enough and they shouldn't be darkening my critical care unit doors. I just wondered, probably Ganesh, as someone who's got real experience in the critical care community, what your reflections on that are?
So that's interesting, isn't it? So I would say, I'm just looking at it from I guess from a conference point of view. If you get on to the ICU conferences, hopefully state of the art, that's mine. The kind of certainly the discussion there tends to very much be all the things we're talking about. Is humanising the ICU, it's early rehabilitation, massive sort of multidisciplinary focus. Thankfully, so a lot of these discussions are led by the physios and nursing and other staff. And so if you just scan the conference programme, which admittedly is a sort of expression of the ideal, the things people are talking about and want to aspire to are very much along these lines of the whole patient and very much the kind of rehab focus. So the days when we used to sit around talking about, everyone's ideal PO2 and just exchanging numbers are to some extent over in terms of the dialogue. How that translates into on the ground at individual hospitals and personalities obviously varies, and I'm already kind of hearing that from both of you. So I'm getting a picture of where I might not want to live. Facetious. So I think there is a genuine challenge in addressing our own perceptions as intensivists. But I think if you look outside that to the kind of current areas of sort of academic stroke improvement dialogue, I think it'd probably be. I think I would hope that you would be reassured actually.
So Ganesh, would it? I mean, there seems to be my personal experience in different countries and different units is exactly as Mike's and other people have alluded to, that there's sort of the people who think it's all critical care. There's the people who think that surgical critical care is very important because those people should get completely better, and there are those people who think that if you don't have multiple organ failure and sepsis, you're in the wrong place. What would be wrong in declaring yourself in one camp or the other and predominantly working there, which is much more of a North American model? I'm a surgical intensivist, or I'm a medical intensivist. Would that be wrong? Because we still seem to stick to this, I'm intensive care, so I can do everything.
I think it's sorry, is that for me?
It was yes, Ganesh, that was to you.
Yeah, okay. So I think for me, I guess the discomfort I have is about introducing step changes into the patient pathway or potential barriers in that. So if it's about the people, then actually, if you had a massive sort of circular ICU or critical care unit, and the people could come and go according to what the patient needed. You could very easily have those who focus on the perioperative side or the acute medical equivalent. You could bring the care to the patient if you like, or you could have units which are adjacent and you could push them through the doors. I think in practical terms, given that there are sort of barriers to escalating and moving up and down, I guess my worry is about the disjunctions in the patient pathway rather than about who does what. Does that make sense? If we could solve that and achieve a seamless transition between all of them, and it's a question of who should be the people to bring each type of care to the patient, I think both medically and with all our multi-professional colleagues, any kind of flexible model is ideal. So this isn't necessarily a turf war about once they enter a certain state, they become the property of the intensivist. It's about how easily can the patient make those transitions as they progress through their pathway, and really with a view to getting that whole rehabilitation recovery aspect into all areas of critical care.
Ganesh, thank you. Now we've got a series of questions have come in from sliding. We've only got 15 minutes left in this session. So I'm going to ask Mike to read them out in sequence. Then I'm going to hand that question to people in the order that I brought them in, roughly, if I can remember. And then if you would like to come in on answering that question, please raise your hand. If you'd like to get rid of that question as quickly as possible, suggest who you'd like to pass it to.
So first up, how do we put this being, I think, sort of intermediate enhanced care, into practice in the COVID era when patients are often not able to see or bring family and friends in for the support that we've talked about?
Denny, could you take that one for us, please?
I'm really sorry. My screen just froze, so I missed the question. Could you repeat it for me?
How do we put in the enhanced care approach into practice in the COVID area when patients are often not able to see or bring in their family and friends for support?
Well, I think we've touched, there's some major challenges to being able to speak to relatives, but I think we can overcome at least some of those by using some forms of technology. So we have an elective level 2 unit, and what we've done there is to give all of the patients iPads, and so encourage FaceTime calls, so at least that they can speak to relatives. So and we give the relatives times twice a day when we aim to have the patient, armed with the iPad so that they can do that. So I think from that perspective, that helps. From the other elements of enhanced recovery, that shouldn't really be affected by COVID in terms of early mobilization. It doesn't require access to relatives, and the early feeding. Again, so I mean, what we've managed, or the organisation, I think one of the things about these different units is that a lot depends on nomenclature, and everybody calls what can sometimes be a similar thing something very different. So in our setup in Southampton is a 10-bedded unit, which is for elective surgical patients, which is staffed by full intensivists, but all of the patients at consultant level, the juniors are surgeons, the majority, and they are all on a one-way trajectory of improving. And if they deteriorate, they go down to our general intensive care. And in that unit, because everybody's elective and nobody has advanced organ support, we sort of ceiling at Optiflow and some low-level vasopressor and arrhythmia treatment, as Mike alluded to. What it means is it's very easy for all of the nursing staff and the MDT to be focused on every patient gets out of bed 3 times a day, every day, and walks. And if they don't, there has to be a reason why, and every patient should be being fed. So, I mean, in some people's book, that would be an enhanced care area, frankly. It's very similar to what Mike described, but we happen to call it a surgical high dependency unit. And in our instance, it happens to be staffed by intensivists. But we're the same people that work downstairs in our overall general intensive care unit. And if patients get worse, they go downstairs. So I think the COVID challenge for communication, really, we have to think about alternative means at the moment. So phone calls and video calls, and the other bits of elements of enhanced recovery we should be able to still do.
Denny, thank you. Mike, next question. I think someone to come in.
Sorry, just can I? But it's just what Denny was talking about as well is about expectation. So there's a lot of expectation that this pandemic problem is going to continue, and we're going to have to introduce digital solutions for care, and that expectation can be introduced very early on in the perioperative pathway, even in pre-assessment, and that messaging has to come through. And there's a lot of work around respiratory care in terms of you tell the patients beforehand they will do their respiratory care post-operatively, and I think the same is with the digital solutions as well. So if they expect to use an iPad very quickly afterwards, I think that will become normal practice.
Thank you. Mike, if you could, the next question, I'll take it to Stuart, if Stuart could take this one.
Interesting, because it's about Mike's talk, so you may, but thank you very much for the talk. Very interested in your final comment about gender disparity. How do you suggest changing this?
That's not the question I've got up next here.
I am actually going to defer that to Mike.
Sorry, yeah, you can. I'm looking at a different question at the top of the list, so apologies. Mike, if you could answer that question, that'd be great, please. Thank you. Did you hear it okay, Mike? Mike might be frozen. So the top of my list I have is enhanced care sounds promising. Nursing staff in enhanced care. What background are they? ICU, theatre staffed, and managed by who? The on-call anaesthetist or surgeons? Stuart, where do you stand on that thorny question?
So I think that's a good question, and I think probably the answer is whatever works best locally. I don't think we can be too didactic about this. I think we're still very much at the outset of this journey. And our unit originated from recovery staff who developed or added in critical care skills as they went along as needed. We have level 1.5 units in a couple of surgical specialties which use their plastics or vascular surgical nurses to run them. So I think really you need to fit the model to what you have locally and what works for you as you start out on this journey. Now, where we'll end up in 20 years' time, I'm less clear, but I think that necessity for plural solutions, I think, is actually going to be a strength of this, that we'll end up with services that are much more closely fitted to what our patients need in our hospital, in our catchment area.
Thank you. Mike, if you'd like to call out the next question, and we'll...
I don't know if I have the same one as you, Monty, but can enhanced care be used to optimise patients prior to major surgery, potentially, or is it strictly for post-operative care?
I think some of our guests have stopped blinking at me, so I'm guessing they're frozen at the moment. So, Denny, your face is moving, so you get that question.
Excellent. The challenge is often capacity for this question, I find, but I don't see any reason why you shouldn't pre-optimise patients that need it. That, on the whole, alludes to emergency patients more than elective, maybe the laparotomy that needs some fluid optimization. But there are occasionally patients that need nutritional optimization, but they don't usually need an enhanced care environment. So the pre-optimization prehab sort of exercise thing is mainly an outpatient thing. If they need to be an inpatient, I would see that they could be in enhanced care in just the same way as a patient could post-operatively. What you really need is the monitoring and somebody immediately available to evaluate the response to whatever sort of challenge you're giving the patient, be it a fluid challenge, for example, and then either give more or less. I think it's worth saying in our enhanced care stroke level 2 stroke 8 surgical HDU, when we looked at the elective patients, only it's about 30 to 40% have a classical level 2 intervention, as in needing an inotrope or needing non-invasive ventilation. So that means about 60% of them don't.
So thank you very much indeed, Denny. So but very sadly, I think we've lost Mike Swart. Now, it might be that he was terrified by the question about trying to expand on how he's going to deal with gender disparity. So we'll apologise to the person who's asked that question. We'll see if we can get Mike to answer it later. So I'm going to, sorry, Mike, to jump down to pick one, because I'm going to take this to Ganesh. Enhanced care unit, does it come under critical care or theatres domain? Now, you can give two versions of that. You can give your presidential answer and your personal answer. You're probably not allowed to do that.
Okay. Well, it's okay, actually. So the presidential answer, I think I mean, the subsequent session covers things like the enhanced care document that
exactly.
Mike did a lot of work on. I had a sort of peripheral bit part in, and actually that makes the point that it's about it doesn't have to be an either or. So you can integrate the governance pathways, standards, skill sets, and work jointly with other elements of critical care, even if you're not sort of within the critical care directorate. So in a way, we should be agnostic as to what the arrangements are, as to what the kind of hierarchy is, but still be able to achieve the same goals. I think would be my sort of total answer. Intuitively, advantages in both. Personal experience, actually, so as a kind of declaration of interest, we have historically had a combined directorate. So I was CD for anaesthesia and critical care for some years, and during that time we set up this sort of model. So it's always been relatively seamless. What we found is that as it evolved and different sort of partitions developed, then we had to kind of negotiate different cultures developing in each unit, and actually keep sort of avoiding that happening, I think, is a key one. So I'd take the middle route and just say both, actually. Where it sits managerially is one thing, but I think there should be elements of learning from both theatres and anaesthesia and critical care, and a sort of mechanism to combine those, whether that's through combined governance meetings or formal pathways. So that's kind of a slightly non-answer for you, but I don't think we should necessarily make the distinction too rigidly.
Thank you. Now, before we get to what I'm going to take as our last question, I'm going to ask you this one, Mike. You can spread it out as well if you want. Mike Grocott, my co-chair. Which scoring system do you use for predicting 30-day mortality? That's one of your areas of expertise, I think.
It is. Number one, we focus less on 30-day mortality. So classically, it's been POSM or one of the derivatives of POSM. I think we are. I suspect we're about to shift to our own, as we have with ICNARC from the Apache model. I think that the PQIP database and data set will be sufficiently mature that we will be able to have our own real-time developing national risk adjustment, analogous to the NSQIP, so the National Surgical Quality Improvement Programme.
Back in.
And we've got Mike back, fantastic. But I think, certainly for elective surgery, mortality is very uncommon, and it's typically late now, and we're much more focused on length of stay and the whole dreaming concept, which you, Monty, have been very instrumental in introducing. The at what point can you get people drinking, eating, and mobilising how soon after surgery, and use that as a measure of success.
Thank you very much, Mike. Mike Swart, welcome back. Can you hear us okay?
Yeah, sorry about that.
Okay. One of the questions that came up was direct to you about your closing comments or comments near the end with regards to gender, and what you think we might be able to do to improve that situation.
Well, the reason I think the gender disparity is so important is I think it will achieve what Ganesh was trying to suggest. I think the changing in behaviour and attitudes needs more females and less alpha 1 males. How you do it is, I think, gender disparity is a really difficult thing to deal with. It probably needs role models. It probably needs the males to recognise that they may be the problem, that they may be putting off females from going into intensive care. Probably the most important bit is we need to talk about this.
Yeah. My answer to that, Mike, should be, well, who says that? But we're nice and cuddly. Yes, please.
So just to chip in, I think there is an important message about modelling, isn't there? And actually, some of that is events like this, where we've got a sort of mixed panel. There is increasingly a dialogue about whether sort of all male panels or single gender panels should be sort of banned. In the critical care, there's definitely moved to that. So not to hype state of the art in intensive care, but we've had that policy for a while, and I think we've got a 40% female faculty by 2017 or so. And actually, if you look beyond that, and that's not just about my society, but if you look beyond that at the leadership in critical care in the UK, I think we've made huge strides. So the Dean and Vice Dean of the faculty, Alison Pittard and Danny Baker. The chair of the clinical reference group is Jane Edelston, and you could go on with all of that. The research body is led by Natalie Patterson. So I think as a sort of modelling and leadership, or the leadership patterns change, people should be able to look at that and go, this is a specialty for me, with the sort of benefits that others have said. So I think there is definitely something about promoting the active modelling, both in conferences and in the way that the bodies are run.
Denny, any
No,
reflections?
I should say all of those were by merit, clearly, so it's not about quotas or anything.
Absolutely. Yeah. So, Denny, Professor Levett, any reflections on that?
I really agree with what everybody said. I think increasing role modelling is really important for trainees. For some reason, I hear again and again that if you're starting off in anaesthesia and considering either doing anaesthesia or critical care joint or moving, to a single specialty critical care, it's felt not to be a good choice for women for some reason. And I think it's really important to have women in post who can challenge that assertion. I think there are some elements of critical care practice, for example, that are actually much more family friendly than anaesthesia. So, for example, in our department, we have 130 anaesthetists, and as a consequence, school holiday annual leave is extremely restricted, whereas there's 15 intensivists and we sort our own leave, and we can have leave in school holidays. Whereas, so that's actually quite important. Also, you can structure job plans to be family friendly. So those are things, and that's not only from a woman's point of view, but it is often quoted as a reason not to do critical care, that it's a terrible quality of life specialty. And I think we need to challenge that, and having more women on the stage at conferences, more women as consultants will help provide and discuss those options with trainees as we come through, and it's really important. I think the element, the positive discrimination is always perhaps difficult at this stage, but I think to get from where we are now to a situation where there is more equal representation, it is necessary right now for the leadership to take a stand that with things, as you suggested, Ganesh, of saying we won't have all male panels, because that just perpetuates a problem. And in a few years' time, there'll be an equal number to choose from, so we'll just go back to normality. But I think you need probably some positive affirmative action to achieve that in the short term. I was a bit shocked when I realised how few women there are as consultants in critical care in the UK even still. So we're still down in the 20%, which was surprising to me and made me focus on it a bit more. Even as a woman, I hadn't really thought about it much previously. But our department, there's there are now 3 of us out of 15, so we're getting there.
Denny, thanks very much indeed. So we need to close this session, but there is just one question left, and I think we should respect and have that answered. So, Chris, I'm going to ask you to comment on the bottleneck in the wards. So certainly in critical care every winter, discharging patients who are ready to be discharged are caught in the bottleneck of the full hospital. So even if we have an enhanced care in wards, especially dealing with these patients in the first instance, won't the bottleneck still get them?
Yeah, I mean that's always going to be a little bit of a problem. But I think if we start to think about this as a continuum of care, we can't particularly ring fence the wards. But I think if we start thinking there's continuum of care with the interaction, and we've talked about this today really, that there can't just be an intensivist dealing with it. It can't be just an anaesthetist. There has to be a continuum of care, and I think that goes on to the ward as well, so that we're aware, the people on the ward are aware what it is and what shouldn't be coming towards them. And I think that awareness may actually improve the not availability, but it certainly will improve the transition from the enhanced care area to the ward care. Capacity issues are always going to be a problem. But as I say, if we can get the continuum of care with physios, with the occupational therapists, etc., then I think that will improve. And I think there is a disparity and a big gap between this. He's on a critical care unit, he must go to the ward, and there's no communication between the two. And I think that communication needs to improve.
Chris, thank you for that, and thank you for all of our participants for this panel. It's going to be a relatively pithy close here. I'm going to hand back to Mike for a second, who's chairing the next and final session, to tell us when we should be back and what's in store for us.
Thank you, Monty, and thank you to all the panel members in this session. So we are coming back at midday, 12 o'clock British Summer Time, for those of you not in the UK. For the final session, which is enhanced care and the future of post-operative critical care in the UK. We've got another all-star panel, and we have Anna Batchelor talking to us initially about the new enhanced care guidelines. So really look forward to seeing you back with us at midday, 12 o'clock. Thank you very much for watching and listening. I'm here with Professor Monty Mythen in Melton Mowbray, the home of the pork pie, as I'm sure you all know. My name is Mike Grocott. I'm a Professor of Anaesthesia and Critical Care in Southampton. I'll give Monty an opportunity to introduce himself.
Monty Mythen, Professor of Anaesthesia and Critical Care at University College London.
And we have a great session on enhanced care and the future of post-operative critical care in the UK coming up. We've got an all-star panel, and I'll introduce those individuals after the presentation, but it's a real pleasure before the presentation to say hello to our speaker today, Anna Batchelor. So Anna, could you, I can't imagine anybody watching doesn't know who you are, seeing as you've held almost all the senior roles in critical care in the UK, but would you mind introducing yourself?
Hi, I'm an anaesthetist and intensivist in Newcastle upon Tyne, and currently sitting in my home, which is an old church just outside Newcastle, surrounded by countryside, so I'm very lucky for lockdown. In critical care, I've been president of the Intensive Care Society, dean of the faculty. I was also on the College of Anaesthetists Council, and hugely enthusiastic about anaesthetists becoming perioperative physicians and developing perioperative medicine. It was the obvious amalgamation of everything that I've always wanted to do for patients, and I think it's really fantastic that we're pushing this forward now.
Brilliant. So Anna, we've got your pre-recorded presentation, which we're going to share with everyone, and then we'll come back to the panel and what I think is going to be a really interesting discussion. So your presentation is all about the new enhanced care guidelines, which you were central in driving forward. Thank you very much.
Hello, and thank you for asking me to speak at a very unusual EBPOM conference. Thank you to Ramani and Mike for setting the scene for what I'm about to talk about. So, how do we get a quart into a pint pot? So for the last 3 years, I've been the clinical lead for critical care for the GIRFT programme, and it's been fascinating. I've learned an awful lot of things. Not everywhere looks like the place that I work in. Not everywhere does the job in the same way I do. And there absolutely is not equity of access to critical care. There's a huge variety of things that change and influence how we work in our critical care units. The culture, the resource that we have to work with, the history of the space we have, the people who've worked there, and the geography either of the space in the hospital or the geography of where we are in England and our connections to other places. And one of the most important things I've learned, and that you will be aware of, is that there are undoubtedly units that are haves and those that are have-nots. Those that have most of the resources you need to deliver an adequate critical care service for that hospital, and those that are struggling, that don't have enough beds, enough doctors, enough nurses, and certainly not enough allied health professionals. So I did a lot of deep dive visits and I learned a lot of things. And then something happened. A virus rather deflected the project. So we are no longer able to do our deep dives, but I think I've probably seen enough to be pretty sure what it is that we need to be changing in our critical care services and how they can work well with perioperative services. Critical care has a moment in time, a moment when we can make some big changes, a moment of opportunity. We've had one of these before. We had it around about the turn of the century, when we saw the publication of comprehensive critical care. Towards the end of the 1990s, A lot of patients were being transferred between critical care units because there weren't enough beds. There was lots of negative publicity, and we had patients dying in the back of ambulances because they couldn't find a bed somewhere. So what happened in the early 2000s was that we got high dependency units, outreach services, trust-wide critical care delivery groups to embed critical care within the hospital service. We got networks, which have now developed into operational delivery networks. But most importantly of all, we got 140 million quid. And that made a huge difference to how we can deliver our service. Does critical care work? So both Ramani and Mike have suggested to you that admitting patients after surgery to critical care does in fact improve their outcomes. And indeed we can demonstrate that critical care has produced better outcomes over the last 10 years. So ICNARC frequently has to recalibrate its SMR calculation, otherwise we would all have SMRs significantly less than 1. So this is data for the last 10 years, which shows that our outcomes are improving. Now, something interesting to look at is what bed days we've been using for the last 10 years. So the blue lines are the level 3 bed days. And you can see that there's been very little increase over the last 10 years in those level 3 days. And that's despite the population of England increasing by 3.3 million people, greater expectations from clinicians and patients. The paler blue line is level 2 bed days. So we've seen a big increase in those level 2 bed days over the last 10 years. Does that tell us anything about level 3 bed days? Now, I can't prove this, but I would like to think that by embedding critical care within the service, by having earlier recognition through the use of news scoring, and early intervention by bringing patients into a level 2 bed before they become, particularly ill with multi-organ failure, that we are able to reduce the number of level 3 patients that we have in our critical care units. And that's a benefit to our patients because that means they're cheaper and it means they're more likely to have a better recovery afterwards. So who is in those level 2 beds? Well, overall, if we look at the patients who are admitted to critical care, more than half of them are patients with acute medical conditions. If we go back 10 years, that was about 2/3 of admissions to critical care were from a medical background. But the big increase, and all of these percentages are average across England, there are very large variations between units, is in elective surgical admissions. But we can't get a quart into a pint pot, and SNAP2 showed us that the only patient level predictor for cancellation was requirement for a critical care bed. So the patients, the surgeons, the anaesthetists get themselves worked up for a big procedure, and then we tell them, no, sorry, it can't happen. Quite ridiculously, if we look at the advice in GPICS 2, we expect this. We think that it's normal. We look at ways of making this service work, accepting that we are going to cancel surgery. Many of you will have watched the absolutely amazing series of hospital programmes, and I vividly remember one where a patient was expecting an esophagectomy and he was brought into the preoperative area and was told on television that there was a patient with an emergency aneurysm coming in from another hospital. If that patient didn't make it, then the esophagectomy patient could have the bed. What a dreadful conversation to have. What a dreadful way to be thinking that we are running an adequate service. So how do we make this better? Well, we need more beds. Do we need those beds in critical care? Or do we need to be thinking of something else? So what do many of our patients need post-operatively? Now, some of them will still require critical care. That is absolutely certain. But for many of them having major procedures, the thing they require is more nursing. That is absolutely the magic of the job that we do. They also need the availability of someone who can intervene or prescribe if things aren't going as well as they might do. They need the rapid availability of a high-level decision maker. Do they need machines? I don't know. They need some, but they certainly don't need to be tied to them 24 hours a day. This needs to be part of an enhanced recovery programme. So patients need to be on their journey towards recovery. So when we developed high dependency units back at the beginning of this century, it was to address a gap between the ward where patients are mostly able to take themselves to the loo, all of those things, and the intensive care unit where we had the breathing machine and all the other machines. We put high dependency units in the middle, but we still have a gap, a huge gap. High dependency units have 2 patients to 1 nurse. When we go to our wards, there are something like 6 to 10 patients to 1 nurse. And as I've already said, the magic of critical care is the nursing. We still have a gap. What could we put in that gap? Enhanced care. The Faculty of Intensive Care Medicine produced a document on this just earlier this year. So what is enhanced care? Well, it's an area that does have more nursing, that can observe patients more closely, but it's also a better environment, a more appropriate environment. It's calmer, it's welcoming, you can have your relatives to visit, single-sex space, a place where you can start your recovery, not a place where you can be stressed by 24-hour-a-day noises and all of the scary things that happen in a critical care unit. So what do we need to do to make these enhanced recovery areas work? Well, we need to sort out appropriate governance. How are they going to be organised? Who's going to be the people who look after the patients? Where is it going to be? What are the operational systems? How do we look after the quality? What data are we going to collect? What quality improvement programmes are we going to have? Who's responsible for that? How do we benchmark the activity between different units? As I said earlier, there is huge variability between what happens in different hospitals about how patients are looked after in different hospitals and the spaces they go to after operations or when they're acutely ill medical patients. We need some standardisation. We need to know that what a patient can expect in one hospital is the same as they can expect somewhere else. So what might this service model look like? Well, we're going to need to decide where these beds are going to go, whether patients have access to toilets, to showers, all of the things that make up a standard ward, but also where we're able to provide a higher level of care. We need risk management processes, and one of the most important aspects for me of risk management is these areas need to be set up properly. It's going to be hugely tempting for the cash-strapped NHS. We've already spent a huge amount of money on the coronavirus pandemic this year to stick up a sign over the door that says enhanced care area and then not pay attention to how the place is adequately staffed and supported and the patient's care is delivered. It might look like you've solved a problem, but you just create a different set of problems downstream. Who's going to staff it? We certainly need more nurses, and there is a bit of a problem. We do know that we have a shortage of 40,000 nurses in the NHS before we started this. But we've had a lot of nurses who've come in to help us in critical care over the last few months, and they've developed a lot of skills and knowledge, and it would be really useful if we could retain some of that and use that in enhanced care areas. Which doctors are going to look after these patients? Is it going to be surgeons? Is it going to be anaesthetists, who I would suggest are really well placed to be part of this perioperative pathway? Or is it going to be critical care physicians? I'm not sure it matters. What the important thing is that everybody knows who's going to be doing it. It's clear who people call when they need to see somebody. One of the things that was very clear in my deep dive visits in critical care is that there is huge variability in the availability of allied health professionals. So physiotherapists in many places are only available 5 days a week, but patients are expected to recover 7 days a week. We don't have availability of occupational therapy, psychology, speech and language therapy, dietetics, pharmacy in anywhere like as many places as we should have, and that really does need to be addressed. We need to work out how the patient pathway is going to work. How does the patient get in? Do we have a booking system? Is this all arranged from the pre-assessment clinic, so it is known how many patients are expecting to get into the enhanced care area each day, so we can make sure that we don't create another place for the patient's operation to be cancelled because there's no room at the inn? Who's going to be delivering the care while they're in the unit? And what are the standard protocols we've got for keeping the blood pressure up, for supplying oxygen, of those things? What happens if a patient's deteriorating? What does the escalation pathway look like? How do the patients get upgraded to high dependency? And then particularly, how do the patients get out? One of the huge problems that we see in critical care is being able to discharge patients to the ward. More than 60% of patients who are declared fit to leave are still there at 4 hours, and almost a quarter are still there the next day. These enhanced care areas will not work at all effectively if we don't have adequate discharge pathways and appropriate patient flow. So what space are we going to use for these enhanced care areas? It could be a bay on a specialty ward, but we do need to bear in mind that a small area with 2 beds is really difficult to staff, because 2 beds, 1 nurse, you've got the same ratio as high dependency. You may as well put them in the high dependency unit. A 4-bedded area, 1 nurse, that's fine, until she wants to go on a break or to lunch. All of these things need to be worked through. One possibility, which is certainly worth considering, is having a post-op enhanced care ward, so that patients of any specialty can go there, and it has all of the systems in place to look after it. It makes it easier to nurse. You can have flexible nursing. Or if you have a relatively small hospital, maybe it just needs to be an extra part of critical care, and as well as having an area of 1-to-1 nursing and 1-to-2 nursing, you also have an area of 1-to-4 nursing. The optimal way of doing things is going to be something that works for your patients, your service and your hospital. It needs to be worked out as part of a team. So this is a huge opportunity for us. It's an opportunity to avoid cancelled surgery. It's a huge waste of time. It's distressing for the patient. It certainly makes surgeons cross as they march up and down the theatre corridor wondering whether they can start their operation. It's a waste of time and money. We could do much better. We can get the right patient in the right place, and we can make enhanced care part of the perioperative care pathway for our high-risk surgical patients. Though we have another opportunity. The coronavirus has not gone away. We'll almost certainly be seeing second, third, more waves. We will almost certainly be seeing a need for critical care spaces where we can, as the waves hit, manage extra coronavirus patients. An opportunity from having an enhanced care post-op ward is when those surges hit, we have a space that's equipped with oxygen, monitoring, that's staffed with people who have enhanced care skills, able to manage oxygen devices, invasive blood pressure monitoring, that know about monitoring unwell patients. So it's an opportunity to balance our service in what is going to be an uncertain future. But most of all, this is going to be an opportunity to deliver the best care we can for post-operative surgical patients in England. Thank you. Thank you.
Great presentation. Thank you so much, Anna. Now, we have been having some challenges with internet, so there's a little bit of Russian roulette as to who I'll actually be able to talk to and introduce here, but we have, at least intermittently, a truly all-star audience. We've got a big panel really composed of the great and good of anaesthesia, critical care and surgery. So I'm going to take potluck and try and do some introductions. I'm going to start with Alison Pittard, who's the Dean of the Faculty of Intensive Care Medicine. Alison, welcome. Can you hear me?
I can, yes. Thanks, Mike.
Excellent. And we have Ravi Mahajan, who's current president of the Royal College of Anaesthetists. Ravi, can you hear us?
Yes, I can, and thank you.
Excellent. Welcome. Dave Salwin, the director of the Centre for Perioperative Care.
Hello.
Welcome, Dave. Derek Alderson, the immediate past president of the Royal College of Surgeons.
My apologies. I'm sorry that I seem to be being cut off on a regular basis.
No, you're doing well. We can hear you. And Dilip Lobo, who's a professor of surgery and long-standing perioptimist. Well, I hope he doesn't mind me describing him that way. Dilip, welcome. Again, almost clear round. So, Anna, thank you so much for your presentation. You've talked us through the background and where we might be going with enhanced care. I'm going to start, Alison, if I may, with you. We're right in the middle, it seems, of this COVID pandemic. We've dealt with the surge in the spring and into early summer. We've hopefully all had a little bit of a break, and now I suspect we're all a bit nervous that it's going to come back again. Now, there were extraordinary promises made early in the year about expansion of critical care, and we can all have whatever we want. How do you think all that is going to play out, and how does that fit with the enhanced care story, particularly in relation to perioperative care?
I think one of the important things is that critical care, as we all know, is more than just a bed and a ventilator. And it's all very well saying we're going to expand critical care capacity, but as Anna said in her presentation, it's the staff and it's the nursing staff that are, the vital part of critical care. So where I see enhanced care sitting in terms of COVID and perioperative medicine is providing that security for those patients who need surgery, who don't necessarily need to go into a critical care facility, but need a little bit of extra care care and support than can be managed on a ward, that then, and I seem to have.
I think we may have lost Alison there. So I'm going to go. Derek, can you hear me?
I think we may have a freeze out there for a second, Mike. So it might be you and it.
You
having
and I.
opinions on it. I think it's a good idea.
Well,
I'm nervous that the, as often seems to happen, the mood music was really, really positive about the funds being available and expansions happen, plans being put in place, everybody getting prepared for what they thought was a great opportunity to expand surgical critical care. And now the discussions seem to relate to, well, there's no money.
Yeah, that does reflect our local experience has been very similar to that.
And there is no money. We understand that. The budgets are very, very stretched. But a bit of honesty is okay about this. If the reality is the funds are not forthcoming because there's hoping that something else is going to happen, or we're going to spend it on a gazillion rapid test kits that may or may not help. I'm okay with being told, sorry, it's now not going to happen. I don't think that's the right decision, but I'm okay with the honesty about it.
I remain unclear as to whether that's going to swing back.
Yeah.
And the notion that we've talked about a lot of having a flexibly expandable critical care facility that you could, for the day job, use for perioperative care with a relatively low staffing intensity, but would be available with a reservist staff for things like the pandemic and major incidents, that sort of thing, seemed like a very appealing concept. I'm not sure where we're going to end up going with that if we don't have a substantial resurgence.
So I'm unfettered from any position in a college now or anything like that. So I think reasonably within the bounds of common decency, speak my mind. It just seems like a no-brainer to me, because we did the temporary expansion. So we bought the kit, we bought the monitoring, we've upskilled some of the staff. Many of them really enjoyed the opportunity. We know there's been a shortfall in the ability to provide this care for very many years. So why not just press on with it? What's going to stop us from doing that? Or maybe I'm just being a bit pessimistic, because every time we've been on the edge of this happening before, I've been let down. But it's only been 20 years of being let down. I shouldn't be too grumpy. Sorry, I think we've got some guests back.
Brilliant. Alison, do you want to carry on where you left off? Or?
Yeah. I don't quite know where we got cut off, but just following on from what Monty says, I agree. It's now a no-brainer. And one of the things that happened during COVID was that, all or the majority of routine surgery was stopped. And so this is a fantastic opportunity to provide a service that patients that need that sort of enhanced level of care can get, have their surgery. It frees up capacity within critical care, so that if and when we go into a second surge, we can maintain some routine activity alongside COVID. And if we have to spill over outside our critical care footprint, we do have a facility that we can rapidly turn into critical care and not go into theatres, so that surgery, other surgery can still continue. So as you say, Monty, it's a no-brainer, really.
But when you're talking with the policymakers and the politicians, do you think the money's, I know it's not in your power, but do you think the money's likely to be forthcoming, or do you think we may have been led down a path a little bit here?
I think, obviously I'm not a politician, but I think they do listen, and that they understand what we need to do going forward. Trusts have been able to bid for money to expand critical care capacity. And what we need to encourage is innovation. And although you may not be able to expand your critical care within the footprint, is looking outside of those walls and developing enhanced care and flexibility and resilience going forward. So I do feel very positive about it all, I have to say.
Brilliant, thank you. I'm going to move to Ravi, if you can hear us, Ravi.
Yes, I can.
So Ravi, you and I and others within the College of Anaesthetists have had conversations about the notion of reservists that we were just rehearsing when the connection dropped. Where do you think most anaesthetists sit in terms of who should be doing that? Do they think that's the intensivist job, it's the surgeon's job? Is it something the anaesthetist should be jumping in and doing? I know these can sometimes seem like slightly divisive questions, but I think that, you know, the workforce is clearly a key issue. Nursing workforce is one of them, but in terms of the medical workforce, how do you think anaesthetists see this?
So if I start with some raw figures, so our very recent survey time, 10% short in terms of workforce. So whether it's the consultant workforce or trainees. So even to run the services normally, without any pandemic surge, there are shortages, as you can imagine, and people being asked to do extra work, and just to, or as waiting lists finished, just to keep the patient flow going. So that's the normal. However, as Alison mentioned, that during previous surge, because the elective activity stopped, lots of anaesthetists, and I must say lots of trainees, they moved to provide help with the critical care patient. And of course, the operating theatres were turned into critical care facility. And as Monty mentioned, lots of supplies came from everywhere, things like ventilators, things like drugs, things like pumps and whatever. I think the question now is how we make best use of what we've got and what we've learned. What we've learned is naturally they would go out and help out if the situation requires that. And of course, if there is not going to be much elective activity going at the same time, you've got that reserve capacity, which will be very happy to move towards the critical care side. Of course, people require cross-skilling, which happens, and that happens quite rapidly with anesthetists. But if I say there are physicians, acute specialists, and there are a number of surgeons, and also a number of A&E doctors who would like to work in enhanced care kind of facility to keep their skills going on for variety of plans, and be prepared to be the reservist in case of pandemic surges. So that is what I gather from my conversations with my colleague in College of Surgeons, A&E, and College of Physicians. So it's not just anesthetists, but other specialists who are very keen to have this facility unwanted. But there is significant proportion of people who are there to help it.
Brilliant. Thank you, Ravi. Derek, I'm going to move to you. So, what I don't want to do is rehearse who should be looking after these patients, but I'm more intrigued in terms of how we organise the care. So clearly there are some patients who are well clear of any sort of critical care, enhanced care, and they're going to sit on a ward that relates to a surgical specialty. And there are others that are clearly defined that are properly sick and they've got organ failure and they will sit on a critical care ward. Where's the margin in between where the balance, the balance between the perioperative care and the surgical care for that specific problem? So where we'd be cohorting them by specialty or cohorting them by, if you like, their type of illness, the perioperative recovering from surgery?
Yeah, I mean, it's a difficult question to answer easily, like, but I mean, collaboration between the specialties that are involved, and whether you're talking about just surgery and those involved more directly in critical care, and some of our physician colleagues in some specialties. I mean, we need to incorporate this as a fundamental part of training in all of our specialties. There is no way nowadays, with pandemics, with an increasingly elderly population, with all of their comorbidities, that the surgeon can kind of think that all these patients can be looked after on a surgical ward, apart from that very few who've got critical illness. I mean, I think that's yesterday's thinking, and I think we've got to try and get the concept into training so that, as we used to have in you might say the bad old days. In my surgical training era, we often rotated through intensive care units and picked up elements of what nowadays we would call perioperative care programs as part of our training. And of course, it was sort of dropped because it wasn't directly surgical. That's nonsense. It was a bad move. It should never have been done. It's to the detriment of everyone, and it's the detriment of the patients. So I think it's getting it back into training programs that's really the fundamental thing in getting people to understand. As has happened in the pandemic, people have learned to work together and to adapt very quickly to a changing situation without lots of interference from colleges and management and various other agencies. Certainly the junior surgical staff in most places just knuckled down to a different job. If they'd been trained to do that better, they would have done it even more easily.
No, I mean, couldn't agree more. It was extraordinary, the response in the spring. I know it's not completely on topic for this, but do you have any reflections on why we were able to be so effective in that context, and we seem so ineffective at moving things forward?
Well, my reflection on it would be that in this crisis, freed from some of the bureaucracies that bedevil the NHS and the interminable tiers of middle management that seem to slow things down at post level, regional level, and even national programs, what actually happened is the doctors, the healthcare professionals, surgeons and anaesthetists working together actually created rapid solutions, got on with it, and actually delivered high quality care free from, say, a lot of bureaucracy. And they did it safely, and they did it extraordinarily well. And I think there's a really important lesson to learn here, and that is that the medical profession, once again, has to provide leadership for the care of patients. And that means, getting more and more of us involved in that process and understanding management and leadership in the health service to make it more efficient, because it's staggeringly inefficient as a rule.
Yeah, very important message. Dilip, I'm going to move to you, if I may, and hopefully you can hear. What is it? I mean, you're a surgeon, but who's had a major interest in a whole variety of elements of perioperative care for a number of years. What is it? What are the elements of enhanced care that are providing benefits, and particularly how do we balance the enhanced care bit with the enhanced recovery bit, which always seem to be in tension a little bit?
Yeah, so thanks, Mike. I think, first of all, I would agree with all that Derek has said. And on our training program, we had a 6-month rotation of surgical registrars through ICU and HDU, and those who went through it found it extremely useful. But unfortunately, the funding for that was pulled, and they don't go through it anymore. And I think to that extent, it's led to some de-skilling of our surgical trainees. Regarding enhanced care, I think we've had a really good system in our hospital, thanks to Dave, Ravi, and the other critical care physicians, who really have increased the bed strength, and there's a lower threshold to take patients to level 1. So we've got a 16-bed surgical HDU, and we've also got a trauma HDU. And now we've got about 4 to 6 beds of level 1 care on the ward. So that has improved care a lot. It's reduced cancellations of operations. It has also led to better delivery of care to the patients. And when they come back to the ward, they're in a much better state, and they tend to go home sooner. The really important part of this collaboration is to recognize the patient who's deteriorating and to rescue them early. And I think, again, the presence of critical care outreach teams has helped that to a great extent, because patients are not lying on the ward overnight waiting to die before they go to critical care. They go to critical care when the critical care physicians can actually do something positive for them and rescue them. So that's made a huge change to our working and also to our results. And the important thing is for surgeons to talk the same language with the critical care physicians. You have to visit the critical care areas every day on the ward round. You have to talk to the consultant on the critical care area and see what needs to be done for the patient. And again, if the patient needs a surgical intervention, be it radiological or endoscopic or even a re-exploration, that needs to be done sooner rather than later. And I think this dialogue between the various professional groups has improved care.
It's fascinating how the themes are not clinical. They seem to be communication, collaboration, leadership, rather than any particular intervention. Dave Selwyn, so you're the director of the Centre for Perioperative Care. It is our multidisciplinary, multi-specialty home of perioperative care, if you like. How should we be, all the issues around it, we've got different groups of people learning the same skills. How should we be doing all the training and credentialing of these folks? Should it be in the individual specialties? Do we need combined some sort of perioperative care credential? Do we need a perioperative critical care credential?
I suspect in conjunction with many of the things we've been discussing, there's going to be a lot of local solutions to this, and there's going to be a number of different solutions to this. So we're a relatively new specialty that's developing and finding its way. And as Derek and others have commented, it's about people working together. It's about people ensuring they've got the right skills and the leadership side of things, the communication side of things. We need to describe what a curriculum may look like, and we've certainly done quite a lot of work on that. And then it's about allowing people the exposure. So you were hearing some of the difficulties with trainees, surgical trainees who have previous exposure, but it's about giving them those opportunities now, ensuring that they've got the teaching opportunities, and then taking that forward to perhaps in the future more structured qualifications and more structured roles. I think at the moment what we need to do is we need to grasp the opportunity that's being provided to us on the back of the enhanced care document and at the same time the pandemic, and really push for this to be embedded as a major development across the hospitals. And I guess if I was going to sort of comment on a couple of the other points that you raised, if I go right back to Monty's point about the funding issues, so my understanding is there's been a tranche of money released to develop whatever you can by December. And the difficulty, of course, with level 3 beds is if you're talking about building or recruiting staff, that's really quite hard for December. But it's what can we do in the immediate term, and then the longer term, actually how many critical care beds and what does that look like in the future will come later. And I don't think we've seen that funding allocation described or released in any shape or form yet. I guess the other thing I might pick up on, Alison was talking about maintaining surgical activity. So I think what all of us are conscious of, it's not just for COVID patients who we're concerned about, it's actually those patients who are being impacted by the COVID pandemic, the people who are on the waiting list. And I have real concern about the increasing waiting lists that we've got and what harm is happening to those patients, because we've got very little sight of what pathology is sitting in those waiting lists and what's happening to those patients. And if anything that we can do to try and reduce those waiting lists or even to hold those waiting lists has got to be absolutely key to us as we go into the tricky time of possibly a second wave and the winter increasing. So I'll stop there and let you come back to me.
Dave, thank you. Well, in fact, I'm going to move to Anna for just a question. Lovely presentation. I'm going to go back to this theme of attention, as I see it, a little bit of a tension between critical care, where we wrap people up in cotton wool to a degree, and they're attached to all these clever monitors, and enhanced recovery, where we're encouraging them to jump out of bed and go to the end of the ward and get their dinner. Any thoughts on the role or reflections on the role of technology and how do we make those? How do we address that tension?
Well, one of the things that I talked about in the presentation was we need to have the environment right. The environment in critical care. Well, it's scary, isn't it? You're surrounded by people who hopefully mostly are more poorly than you are. Things happen all day and all night. You get no rest. it isn't really focused on what those patients need. And it's really important that we get that environment and that mindset for the patients and the staff absolutely right, so that patients know that they're not adopting a sick model, they're adopting a getting better and moving on model. To reflect on what other people have said, it's really tough for an anaesthetist to agree with surgeons, but what both of the surgical colleagues have said so far today is absolutely correct. When I started out in Newcastle, in the intensive care unit there, which was run by Joe Stoddart, he'd set the place up with 3 trainees providing the 24/7 input to those patients. There was 1 anaesthetist, 1 surgeon and 1 physician. That was really hard work, but many of those people became consultants in that hospital, having worked in Joe Stoddart's critical care unit. And the whole philosophy of how you looked after patients, how you worked with other specialties, how you had the focus on the patient. And it isn't that it's my problem or his problem or somebody else's problem. It's our problem. Let's get the right thing for the patient. What I'm really keen to hear, and I like to hear from the surgeons, is this bit about the stitching time saves 9. We really need to take the health service that's currently saying we can't afford this, actually, the leaves have fallen off the money tree, and go, actually, you spend that money. You spend that money on patients sitting in wards with their complications, having longer times of admission, then needing social care support when they go home, not getting back to their jobs. If we get the job right at the beginning, the getting it right first time bit, then we hopefully could actually be doing this job for less money and everybody's gaining from this. And I think we all need to kind of get out of our video conferences, which we've spent an awful lot of time in the last few months, and sell some of these ideas, because that can-do attitude that we had through COVID, which Derek has brought up so powerfully, is currently getting flattened down by that, sort of death by committee, and can we afford this? And, oh, there's another group thinking about that. We do need to take some ownership. We need to be standing up. A bit like Alison did this morning on the Today programme. We need to be out there telling people we can do this job better. Just give us a chance.
Well, hopefully this is part of that advocacy. No, not
Yes.
at all. Hopefully this is part of that advocacy. Now we've got a number of interested listeners and watchers, so I'm going to hand over to Monty to get some Slido questions.
So we should remind people that they can vote the questions up. So this particular question's gone to the top because it received an extra vote. What is the balance for a surgeon in terms of doing enhanced care versus doing surgery? Don't we need a dedicated peri-op medical team?
Dilip, jump in.
Okay, yeah, there has been a move to make surgeons technicians and say you've been trained to operate and just do the operating and leave the perioperative care to other people, such as perioperative physicians. But I don't buy entirely into that idea because, as I said earlier, there has to be collaboration between surgeons, anaesthetists, and perioperative physicians. But I agree, surgeons should spend a lot of their time operating, but at the same time, they need to communicate with the rest of the people. So I am in favor of a perioperative care model, but at the same time, I think surgeons should be part of that team and they shouldn't be excluded. Either they shouldn't exclude themselves or they shouldn't be excluded by others. And that dialogue needs to happen because at the end of the day, the surgeon knows what operation's been done, they know what complications to expect, and they know when to intervene.
So we all got to remember that at the start of it all, we are all doctors, whether we're surgeons or physicians or anaesthetists. I can see Alison's desperate to jump in here.
I think the important thing is for too long we've tried to put people and specialties into boxes, and what we've shown through COVID is we are much better together. And I think we...
Okay, I think we've lost Alison, but Dave also had his hand up. Dave, do you want to jump in? We might have lost everyone again.
Mike, where do you stand on that?
I think the message that was about to be shared with us, which is, we all went to medical school. We're all doctors. The basic values of being a physician, or in fact, that's some being a healthcare worker.
Yes, exactly. I think it should be broader than that.
Are really important, and we get very obsessed as we go through our training with the sort of niche that we sit in as in a particular specialty, and often to the detriment of the patient.
So can we, as a way for our panel to come back in, there's a group of questions which we'll come to in a moment that all relate to accreditation, the requirement to have your FICM, et cetera, and whether that's a barrier and if it really helps in this. But I think we may have our callers back. Alison, are you back with us?
Yeah. So what I was saying is that we need to be flexible, and we have a model of enhanced care, perioperative care, but the patient population that you're going to be treating is going to be very different in different geographical areas. So I think, as Anna said in her presentation, actually, it doesn't matter who is managing the patient in the perioperative setting. It has to be what is right for that patient population and that organisation. And as we came back, we were talking about training and having to have FFICM, etc. I don't think that is about perioperative medicine. Critical care and perioperative care are two different things, but there are obviously overlaps. And I think it's important that for anyone that's going to be involved in enhanced perioperative care, that they are trained to do it. So I don't think it matters the background. I think it's what is right for that individual situation.
So can we pivot into the next question then, Mike? How do we redefine the competencies of consultants who can do this type of care? It actually states critical care to accommodate enhanced care, but if we're recognising it as a discrete a specialty, do we need to crack on and define those competencies, or do we make it more liberal and say, if you're up for it and you're deemed to be competent, please carry on? Alison, do you want to carry on with that for a second?
Yeah. So one of the things the faculty has been doing, along with Health Education England, is looking at the competencies and the training and the upskilling that's happened during COVID, and to be able to recognise those by way of a passport. But then taking it to the next step is to incorporate that into an enhanced care curriculum that would be independent of any specialty, but could then be used in certainly enhanced perioperative care, but enhanced care in general. And perhaps have different levels in that for all the different healthcare professionals. So you have one curriculum that is multi-professional, but different levels, and maybe different modules depending on whether you're perioperative or whether you're medicine or whatever, or maternal care. So that is certainly something that the faculty is looking at along with Health Education England, but we'd obviously want it to be across all 4 nations.
Very useful, thank you. I can see that Dave is trying to jump in.
Thanks. I'm not sure if I'm answering the right question, but just building on that, I think the take-home message about whether it should be surgeons and anaesthetists, it's more about actually putting the patient at the centre and wrapping the care around the patient, as opposed to putting the clinician at the centre and wrapping the patients around the clinician. I think that's the key point. So it doesn't really matter whether it's a surgeon, an anaesthetist, or whoever. And actually, as we go forward, it's more likely to be part of a team approach. And then, of course, enhanced care is not perioperative care in its entirety. It is a component of perioperative care. Don't forget, there's the shared decision making, the preparation, the prehabilitation, all of those aspects, getting the patients ready for surgery, and of course after surgery, after they've left the enhanced care. And so CPOC's trying to work in conjunction with FICM and the various other groups to define these competencies and take these forward in discussions with HE, as Alison was trying to describe. I would say that the various colleges, many of them, so the College of Surgeons has certainly got perioperative competencies within its training documents. The College of Anaesthetists have. So a lot of these competencies are already out there, and it's about lifting them and blending them across the pathway.
So I suspect we can all and would all sign up to the notion that it should be much more about the patient than the doctor, and we're probably guilty historically of defining the care by the doctors. I'd like to come to Derek and then Ravi. You both have led or are leading, the major colleges in this area. What is it about the way we define our specialties and the way we all work together that we seem to tend towards the super specialist and I'm this particular type of surgeon, or I'm a pain doctor who does this type of thing, that's leading us to forget what we seem to rediscover with COVID about the fact that we're all doctors together, and what can we do about that? Derek?
Well, I think very briefly, Mike, I think that the problem, of course, is historic tribalism, and the emergence of specialties in the last, let's say 30 years, particularly as we've developed certain types of surgery into specialist units and in regional centres for complex surgery, etc. And that produced a bit of silo mentality, which I think is unfortunate, and it's a shame that it happened, but it sort of did happen. And we now have to try and unpick some of the parts of that. Of course, what's really fundamental, and even people who claim to be super specialists within a very small niche area have to understand that with an increasingly elderly comorbid population, you will not make good intraoperative decisions unless you have a complete grasp of everything involved in that patient's journey. So that involves the preoperative assessment and what the postoperative course is likely to be if you make a certain type of intraoperative decision. So I really struggle with this idea that some people can be just technicians or just perioperative care. You have to understand it all in order to be able to function in the modern surgical world. And I mean, I just cannot see it any other way. It's the way in which we're beginning to develop our curricula, and that's how it has to be. So the old barriers, the artificial distinctions between people depending on which college they belong to and exactly what type of training they've focused on, become less relevant and should be less relevant. There'll be a lot of perioperative care management in a surgical curriculum. Equally, there needs to be perhaps a bit more knowledge about what really happens in the operating theatre and what those decisions do, you might say, in an anaesthetic curriculum. And those elements exist now.
Thank you, Derek. And Ravi, I wonder if some of the problems are historic in the way that our training has evolved, with the desire for simple or maybe simplistic pathways to get to a very specific, tightly defined goal, and a move away from what many of us did, which was a much more broad-based early training.
Yeah, no, I agree. I think historically, of course, patients weren't that complex about 30 years ago, 40 years ago, and they belonged to one specialty and they got treated by one specialty and they were in the end. But now, as Derek's mentioned, with elderly population comorbidities, you inherently have a patient complex. One specialty can't deal with all the complexities and can't understand and get the grasp and can't be, super specialized in everything. So I'm all for training as a specialist, but I'm not in terms of practicing in favor of specialism. So saying that I'm a surgeon, therefore I'm an anaesthetist, therefore I'm only going to do this is not a professional way of looking at how we practice in the modern times, or how we're going to be practicing going further. So I'll go back to two very basic points which have already been mentioned. One is the training must incorporate enhanced care in all the relevant specialties. The other thing, I've no doubt that 3 or 4 years ahead, so this is back to Monty's question, we will have a credential in, call it in enhanced care, but it's the journey that we have to get to that credential, which anybody, whether you are from an aesthetic background or emergency background or surgical background, you will be able to undertake that just to sign off your competencies or to get extra experience. So that credential in 3 to 4 years, but it's the journey to get to that which requires things like leadership, boundary busting, integration, out nest or stylos, and looking at the patient and the needs of the patient.
Ravi, thank you very much. Now, sadly, we're out of time. I know it's been remarkably challenging with the technological glitches, but I would really like to thank all of you, Anna in particular, for preparing the presentation, but all of you for contributing to this discussion and a remarkable degree of actually consensus and even optimism looking forward. So thank you so much for your time. Thank you for bearing with us with the technical challenges. And to all our listeners out there, that completes our morning of focused on post-operative critical care. We will be back with EBPOM Chicago. What time, Monty?
We've got to get a flight, Mike, somehow.
Oh, of course, yeah.
So we've got we'll be back in 2 hours' time, I believe.
Excellent. So thank you very much, everyone. And we look forward to seeing you in Chicago in a couple of hours. Bye-bye then.